I declare open this public hearing being held at Queensland State Parliament of the House Standing Committee on Health, Aged Care and Sport for the inquiry into the health impacts of alcohol and other drugs in Australia. In accordance with the committee's resolution of the 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and the official transcripts of the proceedings will be published on the Parliament's website. I wish to acknowledge the traditional custodians on whose lands we meet and pay my respect to the elders past, present and emerging of all Australia's Indigenous peoples. I now welcome witnesses from the drug ARM to give evidence. For the Hansard record, would you please state your name and the capacity in which you appear before the committee before giving evidence? This hearing is a legal proceeding of the Parliament. Giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I thank you very much for giving evidence today, and I now invite you to give a short opening statement.
Certainly. So thank you, Chair and committee members, for having us here today to give evidence to this inquiry. I'm Alex Davis. I'm the marketing manager here at DrugArm. I've got some colleagues here with me today to give evidence. Dr. Dennis Young, AM, our executive director for 30 years, but now our chief advocate for the last 5. We've got Emeritus Professor Jake Najman from the University of Queensland, who is the chair of our Policy Council. And we've got Dr. Joseph De Battista, who is the Deputy Chair of our National Policy Council. So DrugArm celebrates 175 years of service in Queensland this year. So we've been doing this for a long time. We're delighted to continue to advocate for addressing the harms and impacts of alcohol and other drugs. Today, each of us are going to talk shortly on some of the key areas that we see. So Jake will start us off talking about some of the trends that he sees in the research and sharing that evidence with you. And then Joe will talk about his area of expertise, which is the sexual health the component of substance use, and then Dennis will speak more to the policy and prevention approaches that we can take to address the impacts of alcohol and other drugs. And as we go through today, I think I just want to take the opportunity to acknowledge the people with lived and living experience of alcohol and other drug harms and use, and their family and carers who are here to assist today and support today. So thank you for the opportunity to be here, and I might pass over to Jake to kick us off with what he's seeing in the research.
Good morning. Thank you for inviting us to speak to you about the harms associated with alcohol and other drugs. Let me just set a small context. I'm an academic researcher. That has a number of meanings. One is that I worry about data and evidence, and see alcohol and drugs primarily as a public health issue which need to be addressed in a systematic and organised way. I think my second focus is that I'm substantially influenced by people like Chris Murray and Alan Lopez, who have developed the Global Burden of Disease body of research. The focus of that research is really to identify patterns of disease in particular countries. Australia is one, but they've worked right around the world, and to orient health systems to the prevalent problems in their particular country, so that the health system is fit for the purpose and needs of that country. And so when we talk about alcohol and other drugs, one of the concerns I have is the extent to which our system accurately addresses the kinds of problems that are prevalent in this country. Let me begin with just a very simple context that worries me. When I look at deaths in Australia as one of the markers, in 2023, there were 84 homicide domestic deaths in this country. 84 men and women, primarily women, were murdered in the context of a domestic dispute. 84. That is one person is too many. 84 is clearly a lot too many. Having said that, let's put that in context. A conservative estimate of the number of people dying as a direct consequence of alcohol use is around 1,750 Australians each year dying of alcohol-related diseases. If you look at illicit drugs, depending upon how you count them and how you count a death, it's somewhere between about 1,500 and 1,800 deaths a year. So we have major burdens of disease that warrant attention and priority. When we look at illicit drugs, it's useful to just get a sense of, illicit and illicit drugs, deaths, it's useful to get a sense of what we're talking about. Cannabis is responsible for perhaps 50 deaths a year, give or take. I'm giving you rough estimates. We don't need to be exact because they change from year to year. Amphetamines, perhaps 450 deaths a year. Ecstasy, a handful, 20 perhaps. Cocaine, 50, 100. Opioid deaths are about 850, many of them prescribed opioids taken by people as part of their medical treatment. So when we talk about drug deaths and alcohol deaths and the burden that they impose on the community, they are both substantial and they're not always in the context that we would expect from what we see in the popular press. There is a gorgeous thing called an age crime curve, and I don't know how familiar you are with it. It's well documented, well known, has been replicated around the world. And the age crime curve begins at about 6, 7, 8 years of age, goes up to about 15, 16, 17 years, and then begins to level out, and by about 25 years of age, it falls off a cliff. It literally falls off a cliff. It just drops right off. What does that mean? It means that when you look at things like violent behaviour, antisocial behaviour, drug use, alcohol use, you get a peak of use around the ages of 15 to about 25, and then after that there is a dramatic change in what's happening in the community. And that is not a matter of dispute, debate. The data are consistent and clear and replicated many, many times. So if we get someone at the age of 18 who drives intoxicated and is killed or severely injured, had we been able to prevent that occurrence and waited a short period of time, that person would no longer be drinking and driving in the way they were. There is this concentration of the problem in a relatively narrow age range. In fact, when we look at the data on drug use and alcohol use, we see that many young people are beginning their careers of drug use before they enter puberty, and certainly accelerating as they get into puberty, 12, 13, 14 years of age, common age to be drinking alcohol and to be using drugs. Many young people are receiving the alcohol from family members and are learning their drinking patterns in the context of their family home. There are a whole range of emerging problems that we need to think about, but we need to understand that many of the issues to do with drugs and alcohol begin very early in life for very many young people and then persist in this age crime curve situation until they get to their 20s, mid-20s, and then the behaviour just seems to, for the vast majority, simply drop off. So when we start to think what do we do and how do we do it, we need to think about the context in which it's occurring. We wouldn't want to be, for example, I wouldn't think, be putting someone 16 or 17 or 18 years incarcerating them or giving them a criminal record of any sort, given that that behaviour in most instances will simply disappear if you wait just a couple of years. So we need to think about the context, the age range that the behaviour occurs, and policies that target the relevant age groups that are most affected. That's not to say other groups are not affected. They are. And the patterns are changing in a quite unexpected way. But it's relevant to consider the peak that we confront. I think the other thing that we need to think about is the context of community attitudes in relation to drugs and alcohol. Essentially, community attitudes are generally disapproving, and professionals working in the field often share many of those community attitudes. We've studied doctors, for example, to look at how they feel about treating people with drug and alcohol problems. And it would be fair to say that our research and the research of others subsequently is that doctors really don't want a bar of it. They do not want to be treating people who've got drug problems. They find them difficult. They do not want to be treating people with alcohol problems. They find them extremely difficult. They lack the skill set, they lack the interest, they lack the commitment, and there is a serious problem in the present health system and in the community more generally in relation to substance use disorders and the kind of effort that many health workers are prepared to make in that context. So attitudes and community values matter in this area and need to be thought about and addressed. I think the next thing we need to think about is the high availability of substances. Drugs are massively available. It really, we keep seeing newspaper reports of the number of drugs that have been apprehended by federal and state police agencies. When you look at what we find out from people who are accessing these drugs, that is, availability, none of those drug apprehensions seem to make any meaningful dent to the availability of the drugs that are there. We've been remarkably unsuccessful. Part of it is the way drugs are being imported into this country. Part of it is the way alcohol is being marketed and sold. All of it makes it extremely difficult to limit supplies. In alcohol in particular, we deal with a situation much like tobacco, much like the food industry. There are commercial interests who profit from promoting behaviours which are unhealthy but which are good for the bottom line. So in relation to alcohol, for example, trying to entice new drinkers, trying to create new products, trying to find ways of attracting people to their product is part of their mandate. With the emergence of online alcohol promotion and sale, particularly the social media use of the promotion of alcohol and alcohol sales, including the availability of alcohol through home ordering and home delivery, we are now facing a whole new range of problems that impact on the availability of alcohol. It is not theoretically, it is practically a situation now where a 15-year-old kid can grab his or her parents' credit card, order alcohol from one of the major outlets, have it delivered to the door, the delivery person leaves the alcohol at the front step, and the young person walks out, picks up the alcohol, takes it inside and drinks. And we have absolutely no capacity to monitor or control that behaviour at the present time. This is not acceptable, and we need to bring legislation up to the current realities of what is a whole new type of exercise, leaving aside the fact that there may be people highly intoxicated ordering alcohol electronically and consuming well past the point of danger.
We might sort of leave your statement there as an opening statement and come back to questions later. If that's
I'm happy for you to ask them now if you want.
Does Dr. Batista want to make a comment or opening statement?
Oh, yeah, certainly. And thank you very, very much for the opportunity to speak. My background is actually in microbiology, and for about the last 35 years working in the area of sexual health and bloodborne viruses. The only perspective I really wanted to provide to the meeting here is to really look at the opportunities we have to finally bring about the elimination of hepatitis C in this country. We have made one of our great public health success stories has been over the last 5, 6, 7 years, the ramping up of successful, effective treatments for hepatitis C, eliciting cures in so many people. However, the real challenge is what's happening in prisons. Obviously, we have a much higher proportion of people with drug use in prisons as a result of the criminalisation of drug use, but that means that we have a higher proportion of people that may have or even currently injecting drugs within prison. I think the estimates are about 14% of prisoners injecting drugs while in prison. As a result, the proportion of prisoners with hepatitis C is going to be greater than what we see in the community, probably about 20% of prisoners with a hep C infection. So that means our prisons are probably the prime centre for where we really need to focus and concentrate our hep C treatments, because that's where we've got the largest proportion sort of congregated together. It's also where we're probably beginning to see the highest risk factors, because what's happening is over the last few years, we've made great strides in ramping up treatment for hep C within prisons. So that treatment is becoming more and more accessible. But the problem is that because there is still injecting drug use happening in prisons, it's a natural consequence. But also, as a result, about 13% of prisoners have reported sharing needles and syringes within prison because clean equipment isn't available. What is happening is the good work we're doing with successfully treating prisoners is becoming undone because of reinfection. And we need to be able to address this in a serious way, the same way we address this in the greater community. So I guess what I probably would leave the committee with is the urgent need to look at what kind of prevention and treatment strategies we can really develop in our prisons. So increasing the opioid substitution therapy, so increasing the levels of drug treatment in prisons, but also, and it's been that little chestnut that's been going around and round and round, making available clean injecting equipment in prisons. I know that has been a very controversial issue, but it needs to be looked at seriously. And so what we're looking at is probably a dual strategy: needle availability in prisons as well as increased drug treatment in prisons, to try to get around this issue of reinfection for people who have been successfully treated but then become reinfected again. If we really want to seriously work towards the elimination of hep C, I think we really need to seriously look at how we can pilot and develop needle availability and increased drug treatment programs in our prisons. In spite of the challenges, I think we really need to take on this challenge and look at it in a serious way. That would be probably my emphasis.
Thanks. And Dr. Young, did you want to make any statement?
All I would like to say, keeping it very brief, is that I'm hoping that the outcome of this inquiry will be the new national drug strategy that's due to expire in 2026. So I'm really hoping that your committee will feed into that. There was supposedly a mid-term review, and I don't believe that ever happened, but it's vitally important that we have these national strategies so that we've all got a platform to work for. From a policy point of view, one of the areas that we like to promote is the known research between moderate use of alcohol and a whole range of cancers that are associated with it. We've been lobbying state governments for a while over that, because I am sure the vast majority of the community wouldn't be aware of the health harms associated even with moderate alcohol use rather than excessive use. Then comes the other areas of strengthening the capacity of the NGO sector, and I believe one of our colleagues, Lives Lived Wells, have put a great submission into this committee about our need for additional resources. All of the NGO agencies in the alcohol and drug sector would have a large waiting list, and it's vital that if someone is motivated to seek treatment, that they're able to get treatment within a reasonable time and not have to wait for weeks and months. In our organisation, we have a long waiting list, and we have a strategy with our clinicians on how to manage that waiting list, because we try to keep in touch with them, but we cannot give them the support they need because we don't have sufficient resources to respond to the real demand that's out there in the community. So they're the areas that we're keen on. The other one is we always have some concern about having the alcohol industry involved in policy development, not necessarily in the implementation, but in the policy development area. Just to name that. And the other one is alcohol warning labels. We've been successful nationally. I think we've got one for pregnancy, but there's a whole range of others. I am aware that some of the alcohol that we export to other countries have to have labels on them. So it would be helpful in this country from a policy point of view to also relook at warning labels as well. There's a whole range of issues in policy, but I think that's probably enough to get the conversation started, gentlemen and ladies.
I might stop you there and we might go to questions, but I'll get my committee members to introduce themselves, starting on my right.
Hi, Dr Michelle Nandaraj, member for Higgins and Victoria.
Mike Freelander, Chair of the Committee, member for Macarthur in outer southwestern Sydney.
Julian Lisa, the member for Barara. I'm the Deputy Chair from northern Sydney.
Anne Stanley, I'm a member for Warrawa in southwest Sydney.
Great. I might. Thank you. I might just start with a couple of questions. And first of all, Professor Dajman, you mentioned that patterns in illicit drug use are changing in unexpected ways. Could you explain what you mean by that?
Yes. We're starting to see a quite unexpected ageing of the illicit drug use pattern in the community. It's coming in a number of ways. One is that we're starting to see more middle-aged and older people affected by illicit drugs. All illicit, but overprescribed. At one stage I looked at the number of people, 65 I think it was and over, who were being prescribed opioids. And the percentage was extraordinary. It would have been somewhere between 15 and 20% of older women were receiving opioid treatment. And I looked at that and I thought that was extraordinary. We're finding middle-aged men being, and Joe is sort of one of the people that no, not music. He's familiar with the issue. He's familiar with the issue. I mean, he may be using for all I know, but no. So you're finding a whole range of middle-aged men are now being diagnosed with attention deficit disorder and being prescribed amphetamines. And so we're also seeing a spike in alcohol use into older age. And we're looking at this and thinking that the pattern of illicit drug use, which used to be tightly concentrated in young people, is now starting to reoccur in a different way in older age groups. And we're just starting to see that pattern spread. And we don't do anything, it's new. And it's not the population we're used to. And a lot of older people, for example, are using cannabis for pain relief. Now, leave aside the question of whether it works or not. There will be vigorous debate about whether cannabis relieves pain. However, many people in middle and older age are now using cannabis for a variety of purposes that weren't the case even a short time ago. Sometimes they're using illicit cannabis because they can't get the script. It's extraordinary.
I agree. I mean, I have some personal concerns about the prescription of amphetamines for so-called ADHD, etc., and a whole range of things. And the prescriptions are going up exponentially.
Oh, it's gone bananas. Yes.
Yeah, but have you seen signs of abuse in older people of prescribed amphetamines?
It seems a little strange. This is just emerging as a pattern. And so we don't know quite what's going on. I mean, one of the big issues here is there isn't a lot of research ongoing. There aren't a lot of places in the country that have any research capacity in the area.
Close to none, I would say.
Sorry?
Close to none.
Yes. Oh, yes. I mean, I was the director of the Queensland Alcohol and Drug Research and Education Centre for many, many years. Under the Campbell-Newman government, the government decided to refocus its priorities on clinical services. So all research activities were defunded. And so our centre was effectively closed. And we were the only state government centre in Queensland doing that research. There is now no government funding, to the best of my knowledge, in Queensland for any of this work. There are almost no centres in the country doing this work. We simply have some knowledge of things going wrong, but we don't have research that tells us what it is and gives us a guide to what we should do.
Yeah, good. Other question I'd like to ask, but I'll pass to my colleagues. Julian, would you?
I first became aware of Drug Arm in the 90s. You were running vans and so on. Do you still run those sorts of services? And I
certainly do. I joined Drug Arm in '88, and that was one of the first strategies I implemented. Can I highlight, when Alex mentioned that we're 175 years old, we're the old Queensland Temperance League. For those of you who may be old enough to remember, we used to have a chain of alcohol-free hotels, one in King's Cross, one in Brisbane and one in Toowoomba. So our history goes back to the temperance movements of the colony. So that's what we've been celebrating this year, 175 years of continuous service. But the street outreach service was started in '89, and it's been running continuously up until now, and it still runs. We get no government funding for any of that, because a lot of the work we do, the drug and alcohol funders will say that's a youth program. And when we go to the youth program, they'll say, no, that's a drug and alcohol program, so we fall through the cracks. So we've managed to do a lot of quite innovative work with our outreach vans. Dr. Debatista assisted us to get a medical van out, and we did a lot of work a number of years ago now in the in the sex workers fields where we used to go out specifically in those areas. But can I say the street outreach is only one. We do education and prevention. We do the whole ambit of treatment except in-house. We have a number of categories of treatment. We have a single intake office where our people get assessed. We have clinical psychologists and social workers, but we also have drug and alcohol counsellors. And we do have day programs where we can treat people with significant issues that don't necessarily have the time or the capacity to enter full-blown residential treatments, or they're quite often mums with young children and they can only spare the day. So, as I said, we try to have a whole range.
Dr. Young, how do you evaluate the success or otherwise of those outreach programs? And given the period of time that you've been at it, what are some of the learnings that we as a committee should take away in relation to prevention policy?
Well, when you say how we evaluate it, well, we evaluate it in a number of ways. We evaluate it obviously with the number of people we connect with on the streets. Our problem is, where we find difficulty is when we refer people to ongoing support with other agencies. Quite often on the street they don't use their own name. It's very hard to, we find it very difficult to track clients to see if they follow through with all of that. The other part of our work that you might be interested in, we would have 20 years now research on Schoolies Week at the Gold Coast. We started doing street intercept surveys because we've been one of the agencies providing support for Schoolies Week at the Gold Coast up here in Queensland now for 20 years. We have a number of our workers inside the safe zone that work with the young people on the actual beach, and then we have another group of young people doing street intercepts in Surfers Paradise, asking them questions on their alcohol and drug use, their behaviours, their sexual behaviours and things like that. So we've been working with Jake and a few others on that. So we've got about 20 years of data on that as well.
What does it tell you?
Can I add one more thing here? Because the question of evaluation is central to what I'm interested in. It's extraordinarily difficult field. Most of the staff, many of the staff, let me not go too far, are appointed for who provide services, are appointed for short-term contracts and often with a skill level that is relatively limited. So much of the service provision in the drug and alcohol field involves contracts with usually state government that are 1 year, 2 years?
Yeah, or 3 years. And in another submission, it has been suggested that to give us the capacity to have highly qualified staff, that we do need up to 5 years funding contracts, because it's very difficult to get key staff to stay if you're on 12-month contracts, because if you've got a young family, it's hard to get a bank loan to buy a house and things like that.
I appreciate these points, and they're similar points that have been made by other submitters.
Yep.
I'm actually really interested in what can we take away from all of your experience in terms of prevention. I think you've got something pretty useful to say in terms of prevention policy. That what's if you had a sort of 3-point plan on prevention policy? It's a lot of P's there that we could take away for the committee. What would you say?
Worry us an enormous amount. The reality is that there is no evaluative data that would make any sense to someone who is in the field, right? So the reality is that when you provide services, as I look at the services being provided, and I've repeated the same question not 10, 20 times, but a lot more. The resources are so limited and the funding is so scarce that there is nothing left over for evaluation. So we continually talk about how would we evaluate and know if we're making any difference. And there is simply no expertise and no resources to do any of that with any of the funding that is currently provided. At the moment, it is a tragically desperate situation of having people in a crisis of substance use coming in for help and being offered support, and that support is often relatively episodic. It's not an adequate state of affairs, and under the current system will continue.
If I could probably just actually answer that, well, just one of the highlights I would probably bring to the table would be that we ignore the social determinants of health at our peril. So if we're going to focus in on any public health issue, to just solely focus on, for example, alcohol and drugs per se as that specific issue, without taking into account the whole dynamic of social determinants, housing, unemployment, education, childhood trauma, then our efforts solely just trying to focus on that specific issue are in vain. So we need to take that holistic approach, looking at all of the social determinants. And if we are developing an intervention, whether it's an educational or behavioural intervention, we need, in a sense, the 5 approaches of health promotion. We need to combine a biomedical approach, education approach, behavioural approach, an empowerment approach, and a social change approach, whether that means, being backed up by legislation. So it means it's a much bigger program of work that needs to be done. It can't just be done by a simple education program or even a clinical service on its own without taking into account those social determinants and those other arms of health promotion.
Thank you.
Thank you. Michelle.
Hi, I just am interested in better learning or teasing out models of care, and I want you to be specific on models of care here. So I've heard conflicting testimony from people. There are some GPs who are very interested in going into this space. Then we've heard from other GPs who say it's too hard, as you mentioned, and just too complex, takes too long, not incentivized to do this kind of complex work. And then, of course, we've seen hospital-based AOD units, which are fine, doing great work. We just visited one, but not scalable, right? Not scalable across this country. And so I feel like we need to better understand as a committee what the ideal model of care would look like. Are we talking about, I'm keen on seeing community-based sites with specialist input, not necessarily medical, because they're few and far between, but maybe nurse practitioners or youth workers or whatever you want to call it, out there in the community, helping people, helping with that early intervention and escalating to care if they need to go into a hospital unit. I think it is challenging to get GPs on board on this. In the ideal world, we would. I just don't believe we're going to get over that line. We've never been able to convince them to do it, and even if we dangle incentives, I'm not convinced that this is going to happen because the clientele is so difficult and challenging. So can you just perhaps give us what you think would be a model of care, community, hospital, whatever?
I used to teach the courses in evaluation at our university, and both in the medical faculty and in the social science faculty. And I used to look closely at the question of what do we do about alcohol and illicit drugs. When I looked at the evaluative data, by far the best result was for people who'd gone to Alcoholics Anonymous. It's crazy. It's absolutely crazy. The proportion of people going to AA who had controlled use of their substances was better than any of the programs that I've seen carefully evaluated, not in Australia because we don't do that, but in other countries and other places. There are programs that work better, but they're resource intensive. They often require skilled clinicians, psychologists would be fine. They would require an extended period of time. They would require engagement with family, and the surrounding environment, as Joe makes the point that a lot of alcohol use is contextual.
Can you just sort of drill down the panel into models of care? What sort of models of care should we be looking at?
Could I just give you a bit of an example of what we do internally? And what we have found is that there's very little preparation for GPs, ministers of religion, even psychologists and social workers in relation to alcohol and drugs. Currently, at the moment, we have 46 students, I guess you could say, as interns in our organisation from the university, usually in their last year. And we do that twice a year, and we're one of the few NGOs that actually take students from the university to give them practical alcohol and drug training. It's unfortunate, though, that that's not recognised as a meaningful outcome of that program. The program is CAFS, the Community and Family Support Services, so they evaluate us on our clients, but we can't sell that to governments at state or federal level that is a wonderful intern training program, and we would have trained hundreds of alcohol and drug counsellors, whether they be counsellors, psychs or social workers, because we give them practical hands-on experience for at least 6 months with us, and a number of them have stayed in the alcohol and drug field. Quite often, alcohol and drug has a stigma with the professional bodies of psychologists and social. They like to try and avoid it. So we've had some success there. So what we've been promoting is the fact that more internships in relation to frontline agencies would go a long way to assisting.
Do you have medical students as well? All these?
We have had medical students, not as many now as we have, but we have had medical students, and we have had nurses, and we've had students from criminal justice. But the bulk of our students come from social work, psychology, or counselling degrees. And they work under supervision of our clinical staff. We've got a clinical psych as our head psychologist, and so they actually get their hands dirty with actual client work under supervision from us and the universities. But it's a great model because we're getting funding to support families and individuals with alcohol and drugs, but on the side of it, we're training the future alcohol and drug force, and we have been doing that for over 15 years. But as I said, it's hard to get governments of any level to recognise that as a valuable contribution to the field. They only look at what we're doing with the client outcomes, not necessarily the student outcomes. So if we could encourage more mentor programs, I think that would go a long way. But you're right, there's not a lot of training even in the medical schools in relation to drug and alcohol.
Final point. When Quadrec was defunded by the state government, we were teaching into the medical curriculum. Much of that teaching stopped with our defunding. You sat there and you think, this is crazy stuff. But, that was the reality of a change of policy.
I might go to Ms. Stanley.
We've had a lot of evidence in the last 2 days about abuse of substances being directly related to other things. So the reason co-options. I'm really interested to hear, given your suggestion that health professionals don't think it's sexy enough to be part of it, how we look at the curriculum they're training to give them insight. So, all right, there's people who are presenting with substance abuse can often be very difficult and hard to manage, but they're people and they probably have other issues with the reason, and, there's a social covenant with how we fund training for doctors and pay them. That means that some of them at least need to be encouraged and given the skills to make them equipped. So my question is, are doctors feeling ill-equipped to deal with these things, or I won't say what I'm going to say next, or like how do we encourage the local GP to pick up issues before they get to crisis, where there's liver failure, where there's Hep C considerations, because they are often at the coalface of where we go for support. How do we make sure that they notice these things?
When a patient turns up intoxicated into a surgery, that patient is a real pain. When a patient turns up drug affected into a surgery, that patient is not a lot of fun. There are dangers to the doctor in some of those situations. Many of the doctors loathe the idea that they have someone who's substance affected in their waiting room or in their treatment area. General practice, I believe, and I've walked away a bit from the field, I'm effectively semi-retired, doctors find their present situation is extraordinarily difficult. General practice has changed so much in the last 15, 20 years. Essentially, we need to revise our whole thinking about the way medicine is being practiced, because many patients are being seen in group practices on an episodic basis, rather than a continuing relationship between the doctor and the patient. And the way the system is currently organised, for example, more than half the general practices in this country, I don't know what the number is today, now belong to central organisations, and the GPs are employees working sessionally in those practices. That is not conducive to building up an ongoing relationship with a patient where you know what they're doing, you know something about their family context, and you can take an interest in them over an extended period of time. We have a serious chronic problem in the system at the moment that we haven't even begun to think about in relation to drugs and alcohol. The underfunding is, I mean, if you want universities to teach drug and alcohol, fund the university to do it. They'll do it because they're hungry for money. I mean, the university is no different to any other organisation. Throw a pot of money at them and they'll trample you on the way to getting it. And if you said to a university, here is a batch of money, what we want you to do is teach medical students, other students as well, about the treatment and diagnosis and treatment of people with alcohol problems, they would jump at it because they would want that pot. But nothing is being done at the moment, and there is no reason for them to do it. Absolutely none. They don't like it. They don't like the patients. They are prejudiced in general terms about the whole issue. And the community on the whole is not greatly on board. Sorry,
If I can cut across there, we do a lot of work with the churches because our member bodies are churches, and you'll find the same thing in the theological colleges. They spend a lot of time on a whole range of issues, but hardly any of them spend any time on alcohol and drugs. And the issue is, quite often they're at the front line as well. People will go there for food parcels, for housing, looking for some help, and yet they don't get the necessarily training either. So that's an area that we've reflected on ourselves in the past as well.
I might just ask one question of Dr. De Battista. You've mentioned about the reinfection rates in prisons, hepatitis C, and of course there are other bloodborne viruses as well. Do any of the correction systems in Australia offer needle exchange programs or?
No. There has been for many, many years proposals to trial a system in the ACT. that has always seemed to have encountered stumbling blocks, particularly trying to negotiate with the relative unions about ensuring occupational health and safety concerns, trying to allay that. But no, we have not been able to get anything off the ground in terms of even a pilot. There's probably about 9 countries in the world that currently do offer this. Australia's been incredibly successful with our community-based needle availability programs. It's the prisons which is the big glaring gap in that area of prevention and follow-up to our successful Hep C treatments in prison. Yeah.
Okay. And perhaps just one last question to Professor Neyman. From what I'm hearing, you are suggesting that alcohol management programs need early intervention if they're going to be successful. So we need to start with children and adolescents.
There are probably 2 arms that you need, I think, to be thinking about. Two types of strategies. The first is the one advocated by Geoffrey Rose in a couple of his papers, where he talks about the disease curve. And he basically says, he relates it to blood pressure, but it works for alcohol, it works for everything pretty well. He says, if we could move the curve of use lower down, that is, to the left, we would save more lives than if we treat the group at the other end. Right. And so step number 1 is we need to be thinking about policies that reduce the overall level of alcohol use. Just gently. No, I'm not talking about banning alcohol, nothing like that. I'm talking about perhaps slightly higher taxes. I'm talking about warning labels on alcohol. Things that are soft policies, but that shift the curve a little to the left. And that is going to give us the biggest bang for the buck by far. The second kind of policy strategy is the people who are consuming alcohol either at a very high level, and their risk is substantial. So we're talking about binge drinking, we're talking about daily drinking of 3 or 4 glasses a day, might be a typical pattern that we want to worry about. Binge drinking defined as perhaps 5 on an occasion on a regular basis. And we want to do something about that group as well. And there, it's not so much early intervention as a treatment kind of strategy. Education probably helps shift the curve to the left. So those are the 2, I would have thought, strategy planks that we want to progress.
Thank you very much. Well, we've run out of time. So thank you very much for coming along today. You don't have any? No. And it's been very, very valuable. If you've been asked to provide any additional information, please forward it to the Secretariat by no later than Tuesday the 12th of November 2024. You'll be sent a transcript of your evidence. We'll have an opportunity to request corrections to any transcription errors. This committee is committed to talking to people around Australia and will run for a significant period of time. So if you have any further information you think would be valuable to the committee, please forward it to us. And once again, thank you very much for presenting to us today. Thank you.
Thank you for your interest.
And thank you for your work as a committee. I think it's valuable. And as I said, I certainly hope it adds to the strategy in 2026.
Great. Thank you very much. Thanks. Witnesses from the Queensland Injectors Health Network to give evidence today. I think we have someone online.
We do have two people in the chorus call as well.
Oh, 2 people.
Good morning.
Morning.
Good morning, Jeff Davies here. I'm the Chief Executive Officer here at Quinn, and I believe I'm joined by my colleague in person, Nicola Hayes, who's the Head Services at Quinn.
Good. All right, well, I'll start now. I welcome witnesses from the Queensland Injectors Health Network to give evidence today. For the Hansard record, before giving evidence, could you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to give a short opening statement of no more than 5 minutes before we proceed to discussion. Ms Hayes, are you going to give the opening?
Mr Davies is going to give it.
Okay. Mr Davey, would you like to give us a short opening statement?
Certainly, I'll do that through the chair. So my name's Jeff Davey and I represent Quinn as the Chief Executive Officer. I'm joining by teleconference. Quinn, we're a not-for-profit charity. We've been providing a range of specialist social and health services related to alcohol and other drug use since 2005. Prior to this, Quiver, Skiver and Jeans provided similar services, and we were an amalgamation merger of these organisations. We continue to work very closely with Quiver, a founding member, and Quiver seek to represent the voice of people who use drugs. We'll make a joint submission together to further the comments that I'll make today. So Quinn, we're a service provider and we provide a range of programs across a fairly unique continuum of care comprising harm reduction, therapeutic or psychosocial programs and primary medical care. We work with clients at any stage of the journey they're at. So what that means is while people present due to needing support with problematic AOD concerns, I should also preface that with the acknowledgement that most people who use drugs will not experience problematic concerns. However, the proportion who do is the proportion we come into contact with through the service system. So when people present, sometimes the underlying reason they're presenting, while they're coming to us obviously for alcohol and drugs, they're also presenting with other social determinants of health. There might be things like employment, housing, parenting, a range of other things. This means that we need to work with people, and often for them, their primary goal may not necessarily about addressing their substance use in the first instance. It might be other goals to do with those things, such as reunification of children, etc. So we need to support our clients with a very broad range of goals in mind. Among our client cohorts, methamphetamine use is high. It's also not uncommon for our clients to report using multiple types of drugs. Alcohol use also continues to be a major concern for people accessing our services. So the people we see presenting the services often have high levels of psychosocial complexity, and traditionally the public service system has found that hard to manage. For many people, there's complex and significant traumas that precipitates their problematic alcohol and other drug use and dependence issues. Many people have also got a history of interaction with the criminal justice system, and that can predispose people to various traumas as well. So many clients we see are also vulnerably housed, and many people also report dealing with concurrent mental health issues alongside their substance use. Well, most people who use alcohol and drugs don't experience problematic use. There's definitely a continued shortage of specialist treatment and harm reduction services in the space to meet demand. I think I need to touch on a couple of stewardship and commissioning issues that persistently hamstring our sector. Firstly, a lot of the AOD services require multiple funding streams to operate more full service, and that's across state, territory governments from multiple departments. For instance, Quinn relies on 18 different contracts to run our programs. So that creates a patchwork of funding that actually raises a number of administrative and financial risks. It creates a house of cards. I think also we've got multiple reporting, multiple compliance requirements. We navigate numerous funding applications and extensions with contracts with varying timelines. There's a nature of short-term contracting for some of our core services as well, such as the NICE, the National Ice Action Strategy funding. There's also administrative delays in commissioning and contracting, which are common. We also see an absence or a complete lack of adequate indexation from Commonwealth service contracts, and that's occurred for the better part of a decade. That in itself has slowly but steadily resulted in a significant erosion of service capacity, and I think it's safe to say that's across the service system itself. It impacts organisations at that system level and therefore the effectiveness and the stability of the system. Part of the chronic funding issue, though, relates back to the equity of resourcing across the three pillars of the National Drug Strategy. That inequitable allocate, so the National Drug Strategy pillars of supply reduction, demand reduction and harm reduction, with the lion's share going to supply reduction. That inequitable allocation of resources results in the inability to meet demand, which is what we see at the ground level. That gap is evident in extensive wait lists and very long wait times. And that can in itself acts as a significant disincentive for people to seek treatment for alcohol and drugs. Access then becomes even more limited in rural and remote areas, which can have some of the highest levels of need. I also need to mention the persistently high rates of overdose deaths in Australia. And I believe that's related to the chronic underfunding of alcohol and other drug harm reduction services. We need a comprehensive response to overdose, and we're now seeing a growing threat of novel psychoactive substances like synthetic opioids, i.e. nitazines and their analogues. We need to urgently rebalance investment to address that. A comprehensive response to addressing that includes things like expanding access to opioid dependence treatment where there's significant bottlenecks in the community, expanding access to important services like drug checking. We need to ensure better drug early warning systems and better overdose monitoring. We need to expand access to overdose prevention centres, and we need to increase availability of and training in the use of naloxone. But a lot of those things I've just mentioned remain politically controversial and subject to ongoing policy debate. Quinn lead drug tracking services in Queensland through a partnership with the Loop Australia, who you hear from later today in Quiver. Even that remains controversial after our elections. A number of priority populations also experience ongoing equity of access issues, and there exists a need to resource and build the capacity of adjacent service sectors, such as those working culturally linguistically diverse communities, LGBTIQA+, housing and homelessness services, to mention a few, to better integrate AAD services, AAD responses and AAD service system responses into those systems. We also see many people who interact with statutory service systems like police and justice and child safety, and many people report a range of negative experiences and impacts from that. We also see people moving between those statutory systems at various times over their life, and that can lead to compounding harms and disadvantage over the longer term. We believe that I think more AAD system support is actually needed in positioning in the broader statutory systems to help effectively address AAD-related harms and help us address some of the underlying social determinants of health. As I mentioned, many people have long and repeat interactions with the criminal justice system. We've seen the introduction of the police drug diversion program in Queensland, which has been a positive step. We also know, because we know that that's increased, that drug offences have actually notably increased rates of imprisonment across Australian jurisdictions, and we know that's disproportionately affecting various vulnerable populations. We know, as Dr. Joe spoke earlier, that people in prison experience higher rates of alcohol and other drug use and poorer health outcomes than the general population, or generally. Evidence and effective approaches to reducing AAD harm do require a health-led response, not justice-led. People in prison often lack the same access to services, health services, that they would in the community, particularly things like needle and syringe programs. In Queensland, condom provision is another key area that we're lacking as well. There's a huge amount of equity in that space. And a lot of that centres on harm reduction and access to essential harm reduction services. Another equity issue that was raised by colleagues earlier relates to primary care, access to basic primary care. Quinn's a unique model. We provide general practice clinic within the services that we provide, but we actually experience a set of unique issues. And I believe those issues are common across clinics that serve severely socioeconomically disadvantaged populations. Really new and innovative primary care funding models are needed to improve equity and access for underserved and socially disadvantaged populations. The actual primary care system itself, it's simply not designed with these types of populations in mind. The other thing that was touched on was the experiences of stigma and discrimination. It's common among people who use alcohol and other drugs. We know it's deeply embedded across society and institutions, and we saw that particularly so in the Victorian coronial inquest into the death of Veronica Nelson. Globally, it's estimated that 7 out of 8 people who suffer from drug use disorders remain without appropriate care. Improvements that contribute to early intervention, drug treatment and increased harm reduction services across sectors that impact people who use alcohol and drugs really requires embedding processes to more authentically and meaningfully reduce stigma and incorporate the diverse voices of individuals in the communities they represent. Most importantly, people with lived and living experience must be part of the important policy and systems discussions and decisions. This, though, in itself, actually, we need to create adequate and supportive systems for that to occur. Such communities really do possess invaluable lived and living experience and first-hand knowledge of the challenges themselves. They understand the stigmas intimately and the systemic barriers that people encounter within society and across these systems. I'll probably leave it there, and I'm happy to take questions from the panel.
Good. Thank you very much. Ms Hayes, do you want to...
No, I'm happy he said what we wanted to say.
Yeah.
Thank you.
Good. I might just get my committee members to introduce themselves, starting from Ms Stanley.
Anne Stanley, I'm the Federal Member for Werriwa.
Julian Leeser, I'm the Deputy Chair and the Member for Barara.
Mike Freelander, Chair of the Committee from Macarthur in South West Sydney.
Michelle Anandraja, Member for Higgins in Inner Melbourne.
Might get you to start, Michelle, if you want to.
Yeah, so again, I just want to, drill down into models of care. You've obviously got a more high acuity, more challenging population, but, you know, from our perspective, we're trying to look at systems change. And we have, we've heard a lot over the last few days about dual diagnosis, mental health. In fact, the College of Psychiatrists said that AOD should be regarded as a mental health problem. And I'm trying to grapple with, well, what is the ideal model of care? We are rolling out over the next year or so about 60 Medicare mental health clinics around the country. And there's no reason we couldn't also add AOD services to these clinics. That would make, to me, that would make sense. And I'm just interested to know how do we broaden this footprint, particularly in the community, given all the problems with stigma. Patients are simply not disclosing their problems to their GPs. It's not easy to navigate the system at all if you are seeking care. And whereas if we have something that's labeled as a Medicare mental health clinic, they can walk in with no stigma attached. Because I would argue that mental health has been destigmatized, whereas AOD isn't. Can you perhaps give us some advice on what sort of system change we should be looking at? Is what I've just described something that we should be drilling down further into?
I'm happy to try and answer some of that. So the Medicare mental health centres, while they may be appropriate for certain populations, they won't be appropriate for all. We've certainly worked with partner organisations in the mental health space to ensure that there are embedded AOD. We're working with some of those partners who are tendering for some of those Medicare mental health centres, new establishment, to ensure there's appropriate AOD services embedded in those models. They certainly do need AOD services embedded within that model. I guess also more broadly adjacent service systems like housing, like homelessness, like services for culturally, linguistically diverse populations, LGBTQIA+, they also would benefit from having resources and specialist support around AOD issues. So again, those statutory systems like child protection, etc., instead of those systems trying to deliver things like case management through what traditionally has been punitive systems, we actually need to be resourcing the AOD service system to work with those agencies and support people coming from a health and social determinants perspective. Quinn's a unique model in that we're providing harm reduction services, therapeutic demand reduction services, and primary care services. Now, I've spoke a little bit about
Can you talk to us a little bit about your primary?
volatility.
Sorry, we're short of time. Can you just talk to us a little bit about what work you're doing with primary care?
Sure. So we provide a general practice clinic. We've provided a general practice clinic we've always provided a general practice clinic in some form or another. We got serious about providing general practice clinic around 2014. We did so because we recognised people were being underserviced in this space. Many people who use alcohol and drugs, despite their level of use, when they actually feel unsafe to talk about that in the primary care setting. Primary care practitioners also can tend to have limited knowledge and confidence in delivering things like basic AOD assessments and brief interventions, and that becomes even more difficult for more complex cases. That model that we provide is a very difficult model to sustain. We see a number of unique issues, I guess, that's common across our clinic, but it's also actually common across clinics that service populations with significant socioeconomic concerns. So you're talking longer consultations compared to more mainstream general practices, because that reflects the complexity of clinical presentations managed in a single consult. GPs are prioritising urgent care requirements for patients. People are presenting with issues like endocarditis. They've got issues around vein care, significant acute traumas, those sorts of things. The current Medicare billing model disincentivise longer appointment times. They really kind of favour shorter appointments, and that puts it at a deficit to start with. The demand for services, we've seen steady increases, but and part of that is driven by the lack and shortage of bulk billing options for populations and low-cost care.
I think we need to move away from just describing the problems, which we're kind of familiar with now, to really focusing on recommendations. So it'd be good if we could use limited time to just maybe focus in on what you want us to see. Would you like to see, for example, 5-year block funding via PHNs? What exactly would you like to see done now?
I would say that there are pockets of general practice and primary care services that exist across the nation that are doing excellent delivery with a range of different population groups, including people who use alcohol and other drugs. We need a system that gives sustainability to those services, whether it be block funding or another mechanism. I think that services like ours would certainly have more stability and ability to attract, recruit, retain general practice workforces, nurse practitioner workforces, etc., if there were block funding models available for those.
Thank you.
Thank you. Mr. Lisa.
Thanks, Mr. Davey and Ms. Hayes. Can I just ask, other than the different stigma associated with people who inject drugs as opposed to other forms of drugs, are there any other responses or approaches to dealing with injective drug users that make the approach to injective drug users different to people who engage in alcohol abuse or people who engage in other substances that are not injected, that we should be considering, given that your specialty is dealing with people who inject drugs?
People who inject drugs are one of the most stigmatised groups out of all people who use drugs.
I understand the stigma point. I wanted to ask other than the stigma point.
Involving people who inject drugs in service delivery. So peer workforces is essential in response to working with populations. Ensuring that the range of lives and living experience is in the community, in the diverse community, is represented. Diversity is key. Our peer workforces are part of that essential element of connecting, building rapport, building trust with that community.
But I suppose I'm getting at the point, are there further infections as a result of it seems to me that that's a real possibility, further infection as a result of injecting drugs that aren't present in other forms of drug use? And is there a need for some sort of specialist approaches in a clinical or medical sense in relation to injective drug use? And because you're injecting things directly into the bloodstream and because of the rapid absorption of it, is there? I suppose I'm asking sort of clinical questions, although I'm not. I'm the sort of one of the two non-doctors on the panel here. Are there some things that we need to think about in relation to dealing with those who inject that are different to other drug and alcohol users? And I ask you this particular. I take your point about stigma. I take your point about listening to people with lived experience. That's all given. I'm thinking about, is there, how are injective drug users different? How should the policy approaches be different, other than listening to them and being concerned about the stigma?
I think one of the things that we need to also acknowledge is there's other population groups who we haven't traditionally thought of or necessarily had good service system responses behind and resourcing. People who inject drugs includes people who are using performance image enhancing drugs as well, so things like steroids and hormones included in that. So ensuring that we're also thinking about those populations in the responses that we're providing is essential. I think that's probably
okay. One more question.
And key to that too is the prison. We're still lacking provision of needles and syringes, some sort of regulated clean supply of needle and syringes in all jurisdictions and states in Australia, which predisposes people to significant harms. Some of those significant harms include bloodborne viruses like hepatitis C, but we're also seeing serious bacterial infections in prisons that are unique to prison environments, and they're causing significant harm to people. We see people in the community who are impacted by things like serious bacterial harms, and they've got significant morbidity. Some people actually have had infections of the spine, leaving them in wheelchairs with lifelong impacts.
Mr. Davey, I wanted also to ask you the final question about your funding situation. We've heard this from many submitters over the last couple of days, that you're constantly chasing funding, and Dr. Anandaraja asked you about the sort of block funding issue. If you had block funding, because obviously organisations often trace particular program funding, but it's not actually what you want to be doing, the particular programs, but you chase the money because it helps you get scale and deliver broader services to a broader clientele. What would you actually like to be doing if you were just given a big block of funding that you're not doing now?
Concentrating on delivering the continuum of care that we deliver across harm reduction, our therapeutic programs and our primary care services. If there was even having better tenure of contracts would make a huge difference. Some contracts have been limited to 1 or 2 years. Having funding that's 3 to 5 years would make a huge difference. Essentially, if we were able to deliver our programs at scale, we're seeing things like the risk of synthetic opioids, such as nitazenes. We actually do need to scale some of these approaches, some of these harm reduction approaches, i.e. drug checking. We're currently available in 2 sites in Queensland that we're providing with our partners, Gold Coast and Burleigh. That is actually needed on a bigger scale. We actually do need to see things like overdose prevention centres, medically supervised injecting, consideration given to those sorts of models, supervised injecting centres, supervised drug consumption rooms. It would actually, they're the types of things that, from a harm reduction perspective, we would like to see enhanced. From a therapeutic perspective, we would like to see better resources to some of those adjacent sectors that I've mentioned as well. We would like to see ourselves able to support organisations like that in capacity building and also in delivering services in models. Some of those services we've worked with are delivering. So we work with a large housing provider who's actually self-funded an AOD program themselves that they contract to us to support, where we're integrated with their in their residential sites with an integrated health team. But they're self-funding that. Currently, there's no funding available for that sort of thing. They're the sorts of service responses we would also like to see happening.
Thank
but
you.
in saying that, we would like to also see resourcing for greater co-design in the establishment of those services. So ensuring that we've got representation from the communities that we're trying to reach, the diverse communities, and people actually involved and remunerated adequately for their time in the co-design of those types of services. And co-design doesn't just start at the design, establishment, implementation of the service. It also includes evaluation.
Thank you.
Ms Stanley.
No, I haven't got anything. Thank you very much, though, for your time. It's been really, really interesting.
I've just got a couple of questions, if I can. It's Mike Freelander here, the chair of the committee. The population that you serve, am I right in understanding, is a very complex one, and have a number of demands on a whole range of portfolios, from housing to education to health. Yeah.
Yes.
So the medical models, the Medicare model, if I can use that one, of transactional medicine is not one that works.
No, so what we, as Jeff has said already, we find that if we can work for our clientele, if we can actually do kind of comprehensive care, where we would have the client seeing the GP or the nurse practitioner, but we'd also have case managers and counsellors supporting that, and together they do a joint plan of treatment for the client.
Health and wellbeing navigator.
Yes.
Yeah. Okay. Is there in Queensland at the moment a service that can provide that sort of comprehensive management?
I might refer to Jeff for that. What would you say, Jeff?
The service system is very much, I guess, because of the way that it's funded, it's vertical. So we're trying to work across the social determinants of health and holistically. Mm-hmm. Our funding comes from a very vertical driven approach. So for our harm reduction, and I guess I'm saying this because the simple answer to that complex question is that the services are trying their best to work horizontally across that sort of holistic approach, and balance things out however the way.
For example, a safe injecting service in Queensland? No, we don't. We do not have so I mean, if you're referring to a supervised drug consumption facility, we do not. In the only states in Queensland, obviously, are the existing ones, so Sydney and a bit, New South Wales. And for medical students, do you know if there's teaching about overdose management, the new treatments, the wider availability of naloxone? Does that exist anywhere? I don't believe so. I could be corrected by someone else on that. The curriculum really needs to be on the agenda. I guess the curriculum for medical students should be on the agenda, and that should be reviewed with community in terms of what we also need to include stigma and discrimination. But that's not just the medical community, that goes across a whole range of professions. Healthcare is particularly important because I guess people are more likely to experience stigma and discrimination because of the disclosures that happen in healthcare settings. But it really needs to be across child safety, a whole range of settings. Certainly stigma and discrimination approaches need to be across the general community as well in terms of from employment workplaces. Naloxone accessibility, the funding, the take-home naloxone program funding has been incredibly valuable, but it's simply not enough. We need naloxone to be more widely accessible. So certainly training and education across a range of particularly first responders. So I'd like to see naloxone training and education in the context of basic first aid across Australia. I think it really should be at that level. And any first responder from security and nightlife entertainment precincts right through to workplaces should really understand naloxone and be prepared to administer in the event of an overdose. And is there adequate availability of the long-acting narcotics like methadone and buprenorphine? Is there a shortage of those services?
Yes. We've seen a significant issue in the prescribing community space, so particularly in general practice. We've got a very high prescriber to patient, a very high patient to prescriber ratio. So we've got pockets of GPs who are prescribing opioid dependency treatment. Very few GPs to the large number of people prescribing, and that in itself raises a whole bunch of issues around contingency. When one of those prescribers retires or exits prescribing, it can potentially leave hundreds of, if not sometimes thousands of people without a prescriber. That is a complex issue that requires a solution to. I really think it is something that both community, states and federal governments need to be working on community around those bottlenecks to prescribing. The other thing that will influence that is, I guess, things like isolation, proximal geography, if someone's rural, regional, remote, how access, natural disasters, all of those sorts of things impact. The other thing is prisons. We're starting in Queensland, we've started to see opioid dependency treatment come online for a broader range of prisoners, both initiation and maintenance. But on release into the community, there's simply not enough prescribers to effectively support the existing patient load as well. So people face significant bottlenecks in
they
access.
leave prison and they go back to their old behaviours because there's not a treatment.
That is correct. And we know that people are significantly at increased risk of overdose the first weeks on release, first 12 weeks on release from prison. So continuity of care post-release is essential also to support people to navigate the complexity of issues. So prescribing is just one issue they'll be navigating. The more immediate emergent things, such as housing, etc., they'll having to navigate that. And that may take precedence over finding a prescriber. But at the same time, we're also seeing people released on things like conditions that they maintain their opioid dependency treatment, but the system barriers are there that it's simply impossible to do so.
Right. That's very concerning. So they're sort of doomed to fail.
Yes, and that's not an individual failure, that's a systemic failure.
Okay. And just one last question, if you don't mind. Are you seeing any emerging trends? And we've heard a little bit about nitrazines, but also fentanyl from other people. Are you seeing any trends in that regard?
Look, I think that we have started to observe, and probably my colleague Cameron from the Loop will be better to talk about this later, but we have seen trends in relation to the drug checking services where we're seeing more counterfeit pharmaceuticals, those sorts of things that people are bringing in. We're also seeing, this probably isn't a new phenomenon, but it's because drug checking, the availability of drug checking is perhaps coming online in Queensland and it's been online in other states. We're also seeing more, there are certainly more likely people to come across adulterants and those sorts of things that are. So I guess in talking about novel, like nitazines have been detected in drugs other than opioids, so they're being detected in things like, we haven't detected them yet in Queensland, although they have been detected by health authorities and in other states. They can potentially be in other drugs like ketamine, cocaine. They've been detected in a range of drugs, which puts people at more increased harm. So people who wouldn't usually be at harm are at a more increased risk of harm as a result of that. And from that point of view, it is essential that we are prepared for synthetic opioids and other emerging drugs. We haven't seen the impact that fentanyl has had in the United States and other countries, but certainly there is a potential for that to happen here. And with already high background rates of overdose, which are 2 times the national road toll, the potential for those sorts of emerging novel drugs like nitazenes is to increase harm is exponential.
Good.
So increased community literacy, drug checking, early warning systems, all of those sorts of things are vital.
Great. And look, I just sort of one question I should have asked you before, but it's great that you've got you are able to provide general practice, but is that funded by Medicare rebates, or do you have to provide block funding for that as well?
It's essentially reliant on Medicare funding, so we run that clinic at a loss from year to year. We don't receive block funding for it. We run it like any other general practice. In fact, if we were to, there's some rules that we found difficult because we can't receive block funding for a particular service like on general practice and then receive the Medicare rebates at the same time. And there is no block funding available. There just simply isn't block funding available for that type of primary care service. We work with a group called the Health Equity Collective, Health Equity Coalition. It's a group of other service providers providing primary care and working with socioeconomically disadvantaged populations like people experiencing homelessness, gender diversity, refugees. We all experience similar Medicare system issues because of the nature of the services we're delivering to a disadvantaged group.
But who pays the GP?
Our GPs are paid as employees. We now operate an employee model with our GPs, and that's also been a decision for continuity, I guess. We don't have a huge retention problem, but we have a massive recruitment problem for a general practitioner workforce. It's very difficult to recruit GPs. That's not uncommon in mainstream general practice land, I guess, but for a very stigmatised, complex area like alcohol and other drugs, it's near impossible to recruit new GPs. So the ones that we do recruit, we've tried to work with them to develop sustainable models, and part of that has been an employment model. We've waxed and waned in terms of GP capacity, so we've gone from 4 to 5 GPs operating. We're currently only operating with 1 GP, and that's because over time GPs retire, exit into other specialties for whatever reason. So strategic decision we face is whether we can even continue to deliver that type of service on the current model, reliant that it is on Medicare. The other issue is we've got a price ceiling for, because of the nature of the severe social economic disadvantage our clients experience, we continue to try and provide a fully bulk billing model. We have considered low-cost options of low-cost care as well. The price elasticity of our clients, it's to be able to afford care is, yeah, that's right. So it's very difficult to even charge someone a $20 out-of-pocket expense when they've got to pull the standard consultation cost plus the $20. That could be $40 to $50 for an appointment. So that represents a price ceiling for us, but for the general practice market, it's a price floor.
Yeah. Good. All right. Well, thank you very much. If there are no further questions, thank you very much for appearing today. It's been very interesting. Thanks for your evidence. If you've been asked to provide any additional information, please forward it to the Secretariat by no later than Tuesday the 12th of November 2024. You'll be sent a transcript of your evidence and will have an opportunity to request corrections to any transcription errors. If there is any more information you'd like to provide to the committee, we'd be most grateful. And thanks once again for appearing today.
Thank you, and we'll provide a submission and follow up by that day.
Thank you.
Thank you.
Good. We'll now adjourn for a short break, and we'll recommence at 12:45. Now 12:45, and we will reconvene our public hearing being held at the Queensland Parliament of the House Standing Committee on Health, Aged Care and Sport for the inquiry into health impacts of alcohol and other drugs in Australia. In accordance with the committee's resolution of the 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and official transcripts of the proceedings will be published on the Parliament's website. I wish to acknowledge traditional custodians of those on whose lands we meet and pay my respect to the elders past, present and emerging of all Australia's Indigenous people. And I now call Mr Cameron Francis from the Loop Australia to give evidence. Thank you.
Thanks very much. Thank you for the invitation to present. So I've only got a short little presentation, then happy to take questions. My role is the CEO of the Loop Australia, which is a not-for-profit organisation established in 2018 to deliver drug checking, or also known as pill testing services in Queensland, New South Wales and Victoria. We currently deliver 2 fixed site drug checking services here in Queensland at Bowen Hills in Brisbane and Belly Heads on the Gold Coast. We also do festival-based testing. We're about to be doing Schoolies Week in a couple of weeks' time on the Gold Coast. We also have delivered a drug checking service at the Medically Supervised Injecting Centre in Sydney, as well as a part of a research project. What I wanted to talk to the committee today about really is the role of harm reduction in the drug and alcohol system within Australia. You've probably already heard evidence regarding the 3 pillars being a little out of balance in terms of how much funding and interest goes into the harm reduction pillar. Harm reduction approaches like drug checking are able to reach new and different populations that are not currently accessing treatment or engaged in the service system. The majority of clients that we see in our services in drug checking are not currently engaged in the system at all, and the majority have never spoken to a health professional about alcohol and drug concerns ever. So we are the first people that they've ever spoken to about their substance use, and from that we're able to identify a range of hidden populations that are genuinely not connected or not otherwise represented. Just as an example of what we're seeing at the moment, just from opening the doors here in Queensland, is significant numbers of people using counterfeit benzodiazepines, and a lot of that is in response to untreated or undiagnosed mental health conditions, and people are attempting to self-medicate using counterfeit benzodiazepines that they're purchasing on the internet. In that context, they're developing things like dependence and, in some cases, worsening of their mental health symptoms. Within that subgroup, we see people with neurodiversity who are using those products for managing social anxiety and otherwise not having those needs met in terms of their neurodiversity, and some sort of links to NDIS, I think, amongst that sort of population. We're also seeing people who are seeking out unregulated medications because they can't afford the medications they're being prescribed by their doctors, and that's straight up cost of living style issue that we're encountering. So not your traditional, I suppose, so-called recreational drug use, but actually people attempting to self-medicate by not being able to access other prescription medications. We're also seeing significant numbers of people using drugs like methamphetamine who are not interested in treatment but are presenting to get their drugs tested because they think the drugs are not working anymore and it must be cut with something. And we're able to show them that that's not the case, that actually it's their tolerance that's causing those changes. And that opens the door to a discussion regarding treatment. And each week, every time we open the service, we see clients in that category who are coming through not seeking treatment, but we're able to point out the impacts of their regular methamphetamine use, and we're able to engage them in treatment conversations. In Queensland, we're co-located with the Queensland Injectors Health Network, who I think may have given evidence today. We're able to walk those people directly into a counselling intake appointment if those appointments are available. The challenge we've run into is by discovering hidden populations, we in many cases don't have anywhere to take them. Our treatment system is already overloaded, as everyone will have been telling you this in other types of evidence. Services like drug checking are emerging. The ACT, Queensland, Victoria is about to commence as well. And as these services open, we are detecting new groups of people who need additional support, and we are struggling to find places to put them. So when you are considering things like equity of access and the current treatment system, enhancing harm reduction approaches does bring us into contact with more people and then puts additional strain on the system that we need to be able to meet. So I think what I'd like to also say is that given drug checking services are here, and now operating, that those need to be considered in future planning, particularly regarding how PHNs do their planning work, and how it is that the sort of additional impacts of drug checking and how that could be met by some of those federally funded services. I also think in looking at the National Drug Strategy and rebalancing the pillars, that it'd be worthwhile to consider the Commonwealth's role in directly funding drug checking services as well. While the states are responsible for the regulatory environment regarding the licensing and the sort of the ways that the services operate, the actual service delivery itself is a straightforward alcohol and drug service delivery type, and it fits really neatly within the existing range of treatment options that we've got, and it should be funded and respected in the same kind of way. I think that's all I had to say.
Good. Thank you very much. I'll get my committee to introduce themselves.
My name's Anne Stanley. I'm the Federal Member for Werriwa in New South Wales.
I'm Julian Leeser. I'm the Deputy Chair and I'm the Member for Barara in Northern Sydney.
Mike Freelander, the Chair of the Committee and Member for Macarthur and Outer South Western Sydney.
Michelle Anandaraja, Member for Higgins in Inner Melbourne.
And Ms Stanley, would you like to start? No.
I'm really interested. Thank you for that information. It's really interesting. You discussed PHNs and their role in this space and future planning. Can you tease that out? What over the country, they can be quite different in what they provide individually, which is supposed to be based on the people that they're working for in those particular areas. But in your experience, how could the PHN support people, those hidden populations with addiction?
I think part of it is just incorporating some of what we're discovering amongst our client group into the future planning, so that as those plans emerge, that we're able to identify those populations. We've had some real geographical challenges here in Brisbane, given that a single drug checking service in Brisbane is attracting people from all over southeast Queensland, and that's potentially across a number of different PHN networks that those people are coming from, and so there are some inconsistencies across the different districts as to what options are available for people across those different regions. So some of it for us has been geographical around making sure that there's alignment across the different areas, but also it's just being able to make sure that the information that we're collecting is being able to be fed into those processes and then adequately resourced to meet those needs. Some of it is outside of the scope of the PHN in some ways, because we are, for example, the benzodiazepine dependence often requires a medical response, and often that is a state government response in many cases. The public health system has to manage that. So we do encounter some sort of gaps between the state system and then the non-government system in that regard as well.
In these hidden populations, in your view, how long will it take their addiction to become visible?
It depends a lot on the substance and the person, but some of the benzodiazepines that we're seeing people using at the moment can start to produce, so like we call them sort of rebound effects, which is really the beginnings of the withdrawal, and that can occur within 4 to 6 weeks of someone starting to use those substances. So what they'll notice initially is that when they don't use those products, they'll experience increased anxiety. And that really, in a lot of ways, is the beginning of some of those withdrawal symptoms commencing, and those early symptoms can be quite quick. What we're seeing is people then taking more in order to avoid those symptoms, which they then, in some cases, is actually underlying anxiety. In other cases, may not be. And it's really hard to determine that. We need, in a lot of cases, we need some of these people to be referred to psychiatry, and we have significant barriers in getting access to both, particularly public psychiatry, where most of these clients at that early stage wouldn't meet criteria for a public mental health service, and then the private psychiatric system, people can't afford the gap payments in order to get those appointments. In some cases, we've had clients where we think there is a GP involved, but the case is a little bit out of their scope, and you can tell the GPs are struggling with that, but not able to get even a single appointment with private psychiatry for a medication review and an assessment.
If you have a particular concern about a client, which clearly you see every day, people, I assume you aren't funded to follow them up, no. Do you? And how does that work?
So drug checking services are completely anonymous. We don't collect any identifiable information about our clients. So it is completely anonymous interaction, and it could be as brief as 15 minutes, but our staff may have people up to an hour and a half in an assessment where we consider that there's some risk. What we'd usually try to do is check in on, do they have an existing GP? Is our number one port of call, is to see whether or not we can get the person back to their GP for a conversation about what they might need. We might send the client away with a little piece of paper of like, go back to your GP and request the following: a referral to private psychiatry for medication review. We might also provide them alcohol and drug information service, or ADIS, I think are giving evidence today. ADIS is our one-stop shop telephone referral service as well. So we might offer an ADIS referral to the person as well. That we aren't really able to follow people up beyond that, other than to let people know that they're free to come back and see us if they want to, without even having drugs checked. I mean, people can just present for another chat and that's happened a number of times where people will come back because they've had a positive experience and tried to follow up with us on how to move forward.
And that starts the conversation, which is really what you need to do.
Yeah, I mean, for most of these people, we are the first person they've ever spoken to about it. So our goal is to provide a really positive experience for people, so that they experience a non-judgmental and, relaxed kind of approach. And that is what we've been able to do. We've seen that in the client feedback.
Thank you very much. Very interesting. Thank you. Thanks, Chair.
Good. Mr. Francis, I want to understand a little bit about your funding and regulatory environment which you operate in. So who funds you?
So in Queensland, we're funded by Queensland Health. There's a 15-month implementation pilot project which runs until April of next year. And there's an external evaluation underway run by the University of Queensland. So we have a licence to handle substances under the Medicines and Poisons regulations here in Queensland, which is very similar to the licence that universities or whatever might hold in order to handle illicit drugs for the purpose of chemical analysis. Our clients are protected under a Queensland Police Service operational guideline, which is a similar guideline in place around needle and syringe programs and opioid treatment services, which just ask QPS to not conduct unnecessary person checks in the vicinity of harm reduction services like needle and syringe programs or drug checking services. So there's no particular sort of amnesty that the clients have. There's just an operational guideline for QPS to not sort of conduct unnecessary checks around that. And they're the two sort of elements that you need for a drug checking service to operate.
And you also provide the same service in New South Wales, did you say at the beginning?
We have conducted a research project in New South Wales at the Medically Supervised Injecting Centre. So New South Wales has legislation which allows clients to possess substances in the Medically Supervised Injecting Centre. So clients were essentially already covered under that. We sought a general approval, similar to Queensland, under the Medicines and Poisons regulations in New South Wales, to conduct a research project where we co-designed a model of service with the client advisory group and then ran the service as a normal drug checking service in order to understand client satisfaction with it.
What are your reporting obligations?
So New South Wales was a research project. So that was a straight, it's going for peer review publication. Here in Queensland, we provide routine data back to Queensland Health monthly. What
sort of data do you provide?
So we provide pretty comprehensive data on the demographics of the clients accessing the service, the samples being presented, what people expected they were, what we have actually detected, so the gap between expected versus detected. We also have a requirement to notify. We also document the content of our harm reduction intervention conversation, including any referrals we make. We also document the client's stated next outcomes, next steps beyond using our service. So we'll ask them after using our service, what do you intend to do? And it might be discard the substance, use the same amount, use less, whatever.
And you report on an annual basis to the Queensland authorities?
So at the moment, we send our reports through monthly. And there's no actual annual report. We do monthly reports directly to Queensland Health and then quarterly reports to the funding area.
Tell the committee about some of that data that you're reporting to Queensland. What's it showing?
It's showing that very high levels of satisfaction of the service amongst clients who are extremely happy with it.
So I'm not asking that. I'm asking about your demographics, about the usage, about what people do. Tell me about that. Yeah, exactly.
Yeah, we're seeing a wide range of ages. The age range is 17 to 80, and that's consistent month by month. We see majority males. It's about 3/4 males to 1/4 females, which is similar to needle and syringe programs. The drug most commonly presented is MDMA MDMA, followed by methamphetamine, cocaine, or benzodiazepines, and the second, third, and fourth bounces around a little bit each month. Most drugs are as expected. We aren't seeing huge ranges of contamination. We do see contamination occasionally, though. When we do, it's often quite bad. So we have found things like counterfeit.
What do you do when you're seeing contamination in places? I mean, given that everyone is getting these drugs from illegal sources, what are your obligations in terms of law enforcement too?
So we do share information with law enforcement. I mean, Queensland Police is on our project reference group, which meets quarterly. If we identify a substance of serious concern, then we report that through to Queensland Health, who are responsible for informing the other stakeholders. If we encounter a highly dangerous sample, that's fairly uncommon that we're encountering the highly dangerous samples. We're mostly encountering samples that are, I'd say, moderately risky for people.
What do you call a highly dangerous?
Highly dangerous sample would be one that has an imminent risk of harm for anyone who consumes it. And an example of that is we recently had a substance that was believed to be methamphetamine, but actually contained methamphetamine combined with a novel ketamine analogue. And anybody who injects that substance will be in quite a degree of discomfort and trouble. And so that's one that is pretty much guaranteed to produce a pretty severe outcome in anyone who uses it. Some of the less, I'd say, more moderate risk substances would be things like cathinones substituted for MDMA. Those wouldn't routinely result in someone, say, needing to be hospitalised. The person would be uncomfortable and have a fairly unpleasant night, but it's not likely to produce sort of someone requiring hospital treatment, whereas the methamphetamine novel ketamine analogue example could well require ambulance call out, so that definitely needs an urgent sort of response.
Confiscate that drug from people if they bring it to you and it has that, or if somebody's bought you a very large quantity of drugs, what are you able? I mean, can you play a role like that in terms of the reduction of supply or the? I am conflicted about what you do because I think in many respects you're to some degree saving people's lives, but also these people have all got their things through highly illegal, life-destroying, organised criminal networks, and I'm not sure that. I'm not sure that I thoroughly approve of pill testing.
Yeah, I mean, I don't believe people deserve to die for those choices. What I think is that we don't confiscate drugs from people. We test drugs with people's consent. They provide us those drugs voluntarily. And if we encounter a highly dangerous sample, we have a conversation with someone about that. And we're very successful at getting people to hand those over for disposal. So one of our last month's reports, we got a 100% discard rate in an unexpected result in our client group. And that's down to the skill and experience of our staff who are able to have those respectful conversations with people.
The sort of people that are coming in, are they coming in order to take, or are they in large part coming in because they're actually looking for you to discourage them? What's your sense of that?
There's a big mixed bag. We've got lots of people who are genuinely concerned about contamination in the drug market because they hear about that and they're aware of that. So a lot of people are genuinely really concerned about it. We have some people who have had bad experiences in the past, which has made them extremely nervous in the future. We sometimes have people that have used some of the sample and had an unusual effect, and so brought it in because they have had some unusual effect from the sample that they still have remaining. That's a range of different reasons that we see.
On the demographic issue, are you seeing people from called communities in large numbers, or is it largely an Anglo-European group? What are you looking at? Is it what's the Indigenous engagement with your services?
Yeah, we probably got lower than expected Indigenous engagement, which has been a bit of a problem for us in terms of how we increase that. I think also the fact that we're seeing predominantly males means that there's more work to do in getting more diverse access to people. We are only open 4 hours a week at both locations, which is really limited. So I think in order to access different population groups, we need to really expand and actually offer our service within the organisations that those people are already connected to. And that's the best way for drug checking to reach the broadest range of people in the population.
From time to time, you'll hear about people going to music festivals and that there are agencies such as yourselves at music festivals. Do you participate in that? And are those agents so people are going and getting the same service from you at a music festival that they would do at your
Yes.
clinic?
Correct.
And is most of your clientele through walk-ins in the clinic, or most of your clientele through some of outreach occasions like that where there'll be a large amount of drugs present, like music festivals?
We've only been contracted to do one music festival under the current funding arrangement that we've got. So music festivals are high concentration events though, so we're able to, the music festival that we've completed, we tested 230 samples and engaged with about 170 people over a 3-day period. The current services we've got in Brisbane and the Gold Coast would see sort of 10 to 15 people per 4-hour opening period, and we test between 20 and 30 samples.
Can you give us a sense of the weight of drugs by type of drug that you've tested over, you might take this on notice, over the course of a 12-month period?
So we've been open since April. I'd have to take it on notice. MDMA would be number one across that, but then the second, third and fourth numbers have changed around quite a bit, and that has varied from month to month. I think our first month, benzodiazepines was the second most common, and then that's dropped in the third month. So it jumps around a little bit.
Are there any substances that you can't test for? Are you how are you keeping ahead of the manufacture of new drugs?
There are limitations to some of the testing equipment. The drugs do move very quickly. We send any sample that we're not able to get a clear result, we send for secondary analysis at one of our partner labs to get that follow-up testing done. So there's a couple of different ways to answer that question. Our FTIR instrument can detect samples that are not in our library. So that's a known unknown. It means that we can see a compound in there which we can't identify. That's enough to say to the client that you've got something really dangerous, because our libraries have thousands of drugs in them, and if we find something not in our library, then it's likely a new drug that you don't want to take because of the risks associated with that. There can be traces of drugs below about 5% concentration that our instrument may not pick up. The ones that we're most concerned about there are things like fentanyls and nitazines. So we use nitazine and fentanyl test strips, which are more sensitive, in order to try and counter that. We also use reagents as well to try and understand if we're missing anything else. So far, we haven't missed anything.
My final question is this: if somebody comes to you and they present you a sample and you test it and you give it the OK, and they subsequently take it and have an adverse reaction or their death is caused, are you indemnified under the regulatory or legislative framework? What's the culpability of your organisation in relation?
We don't give anyone an OK. I think this is a common misconception of drug checking services, is that they somehow pass or fail the test. We actually explain to the person what we believe the compound to be in their sample, and we explain the risks of that drug to the person. So there is no green light passing or failing of a test. There is no particular indemnity that we're under here in Queensland. We instead read a disclaimer to the client explaining the limitations of the testing equipment to all of our people who come through the service, and the model of service is to explain the risks of drug use to people and strategies to minimise those risks.
That's been very helpful. Thank you, Mr. Francis.
Thanks. Michelle.
Hi, Mr. Francis. Really fantastic work that you're doing, by the sounds of it. Sounds like it needs to be scaled up, to be honest. Can you perhaps talk to us a little bit more about the linkage to care? This is a real this is the missing middle, I think. And it's really challenging. And, we don't have enough of the workforce yet, whether it be psychiatrists or psychologists or community youth workers or nurse practitioners. We're working on that. But what is the role, do you think, of, say, a credible, reputable online resource to direct people to? I've heard that there are a few, but they're very fragmented. They're not well advertised. Do you think there's a role for building up an online resource for people to go to while they're waiting for an in-person consultation, for example?
Look, there may be a role for that. I think in Australia we could scale up pretty much everything that we're doing right now and probably still have gaps in it. So I think there probably is a role for that. What we're seeing more so is a need for real on-the-ground support, though, because we're seeing people who need things like appointments with psychiatry for medication reviews and enhanced peer workforce to help engage with people and get them into those types of services, or to make those services more, friendly for those types of people. So, I think there can be a role for online. I think that at the moment we've got some pretty critical needs for in-person real-life services.
It takes a really long time to make a psychiatrist.
Yes.
Can you talk to us a little bit about what an enhanced peer workforce would look like?
Yeah, I think that the role of peer workers should be looked at sort of across the service system spectrum. because we know that peer workers are really good at engaging with people and creating warm and friendly environments, and particularly in those more medicalised types of settings that can be very clinical and very threatening for people. We are encountering quite a few clients who've had negative experiences in mainstream drug and alcohol services or mental health services and experienced stigma in those environments, and including in services where I think if you spoke to them, those services wouldn't believe that they were stigmatising, but that has come out in the client experience. And so I think that embedding sort of not just peer workers at the ground, but even higher up in the planning and management of some of those services can actually make them more engaging. One of our roles has been really to try and encourage people back into the system after having those negative experiences. And I think that's where the peer workforce can really...
Where would you put these peer workers?
Look, I think they should be across the system. So I think in things like government hospital-based detox and withdrawal services would be one. I think in community-based mental health services, I think a lot of our clients experience extreme stigma in the mental health system. And I think they do have mental health peer workers, but it's a very different experience for those people compared to the alcohol and drugs peer workforce. So I think drug and alcohol peer workers in the mental health system is really important to help that system. I think government services, NGOs, I think at the planning level as well. So I think in places like, and I know PHNs have done quite well in some regards to that in terms of getting lived experience into the procurement and the service system design level as well.
How would we, so if we wanted to expand a peer workforce, and just to be clear, you might need to define that for our benefit. I take that to mean people with lived experience who are then professionalised up to maybe a certification type level. So if we wanted to expand that group of people, how would we do that?
There's a range of things that need to happen around that, like particularly around the qualification framework and the sort of career pathway for people to get what is the right training and what are the various levels. At the moment, there's some initial work on that, but it's pretty limited and it doesn't have a really extensive career pathway for people beyond some of the direct service delivery as a peer worker. So I think it's expanding the career pathway into those policy positions and beyond where they are at the moment, which is mostly at the front line.
Where would they get that training? Would it be at university, TAFE? Where do you think?
I think there'd be a combination of those things. So I think that TAFE is a good place to start because they've done a lot of that work already and some of those qualification frameworks already exist. I think that the university sector is another option as well. There are plenty of people doing nursing degrees, social work degrees and psychology who have got lived experience, and that's not allowed to be visible in some of those professions. So we've got a extensive lived experience workforce right now, which is hidden in a lot of ways because of the ways that those professions have operated.
So TAFE has been a runaway success we removed the cost barriers to courses, and so 500,000 people have rushed into TAFE across the sector, including care economy. We haven't really drilled into the AOD workforce, but that is an opportunity. I'm guessing if we did design a TAFE course, there would have to be some placement involved as well, right, to reach certification. How long would that training need to be? Could we get a decent product, if you like, at the end with 12 months, or would we need it to be longer? Do you have a sense?
That's a pretty tricky question. It would depend on the types of work we're expecting them to undertake once they've landed. So I probably struggle to answer that specifically. I think that something that definitely would help would be additional support when people do first enter the workforce. So beyond just achieving the qualification, that first year or two in the workforce is really crucial, I think, in how people land and how they really, develop those skills in once they've graduated. So I can't really answer how much placement would be useful.
And with the Loop, do you have a national network of other groups, similar groups that you liaise with?
There's only one other drug checking service operating in Australia, which is Pill Testing Australia, that operate in Canberra at the moment. And so that's really it. I mean, we've only got ACT, Queensland, and now just Victoria's just passed its legislation yesterday. So it's really an emerging sector. We do all connect via the NO, the National Clinical Research. The NCRED has established a prompt response network.
Sorry, what are they?
It's the National Centre for Clinical Research in Emerging Drugs, and they have been funded by the Commonwealth to establish a national early warning system for emerging drugs of concern. They've built a website called The Know, which each of the states are sort of represented in, and that's become the forum where a broad sector of people gather to talk about things like emerging drugs. And the drug checking services are very active in that network, in that we detect a lot of the new substances that people are talking about.
Okay, so it sounds like it's very piecemeal at the moment. It's ad hoc. There's no sustainable funding model. So this is a space the Commonwealth could definitely support. My last question, really, just to get you to elaborate on what unregulated medicines are. You did mention that cost of living people are seeking these out. What are they?
We refer to unregulated medications as anything that's purchased not on the regulated market. So that can include pharmaceutical products that people purchase online. Those might be counterfeit or those might be legit. So we refer to them as unregulated in that they've been purchased outside of a regulated system, which means that we are unclear on the contents or nature of what might be in those substances.
So you've got some elderly people who are coming to you. What are they presenting with?
We've had people presenting with things like weight loss medications that their GPs prescribed them a weight loss medication. They've gone to fill the prescription and they can't afford it. So they've gone online and searched for weight loss medication on the internet and imported something from overseas and then brought that down to us to have it tested because they are aware that there can be counterfeit substances.
And you can do that?
Yes.
Wow. Okay. Thank you very much.
Thank you.
Yes, thank you. I've got just a few questions, and I'm pleased to hear that your demographic includes up to age 80, and I hope that I can go to a music festival and have my statins checked by you. I really think that this is obviously an emerging space, and I have been a strong supporter of pill testing because unfortunately we did lose a young girl from my electorate with a drug overdose the year before last. So I think it is important. And I was interested to hear you talk about counterfeit benzodiazepines. I mean, they're pretty cheap anyway. Are people really counterfeiting these drugs? Are you seeing that?
Absolutely.
How are they getting them?
Mostly so these are available in the same ways people purchase other types of unregulated drugs. So from their local supplier or from online, in some cases from apps or just directly off the internet. Some are from what look like legitimate overseas pharmacies, but most are more so in what we'd consider the regular unregulated drug market. I think since the things like real-time prescription monitoring has rolled out, I think GPs have become more reluctant to prescribe benzodiazepines, and we've probably shifted people more from that regulated supply via the GPs into the unregulated market.
More of them online from overseas than they...
Correct.
And what's your experience of the purity of these things?
They're mostly counterfeit. We have found some that have turned out to be legitimate. The majority of the counterfeit Xanax that we've encountered so far contains a compound called bromazolam, which is a novel benzodiazepine that's not used in medicine but has been unregulated in overseas markets, which is why there's supply available internationally.
Is it dangerous?
Yeah, it really can be. Yeah, bromazolam seems to. It's a really tricky one because no one's done much research on this, but we've got a lot of client reports that when they take a high dose, including in one case a single tablet, that it can result in multiple days of amnesia where people can't recall what they've done. And so we don't exactly know why that is in this compound, but it's definitely something that people have been reporting, and it's really concerning.
Okay. And you said you've worked at the injecting room in King's Cross. What are you checking for there? Because these are, rather than pills, these are injectables.
Correct. We test all drugs. So, I mean, the reason we refer to it as drug checking and not pill testing is that the pill testing language makes people think we just test pills, but we test everything. So at the injecting centre in Sydney, we test everything people present with down there, which is drugs like methamphetamine, heroin and cocaine were probably the most common samples that people were presenting down there.
And you're finding reasonable purity, or...?
We can't test for purity. We can test for major and minor components. Right. So I can't really comment on too much of what we didn't discover anything in Sydney that required an urgent alert. Because it was a research project, we were sending all samples off for secondary confirmatory analysis, and we're still waiting on the last of those to come back. But we didn't find anything that required an urgent alert in Sydney.
Yeah. And will this be the first year you're going to schoolies?
Yes. Yep.
And presumably that will require quite a large workforce.
Yes, it's going to. Yep.
How many people?
So we've got a casual pool of staff, and so when the service is operating, we'll operate with 5 chemists, 5 health and harm reduction workers, and 4 peer workers. We'll also have a medical officer on site as well for secondary consultation if we come across anything a bit unusual.
And what sort of data do you check? Do you ask people's postcodes, or do you
We do.
ask where they've got them, or
we
how
do.
they've got them?
We ask a range of questions which are all completely voluntary, so people can prefer not to say any question if they want, including every single question that we ask them, and we'll still provide them a service. But we do ask demographics, including postcode. We do ask people some general questions around where they've acquired the sample. In that, did you purchase this off? Was it a friend who helped you get this, or was it a professional, commercial, so-called dealer? Was it from the darknet or the internet? And also, was it purchased in Queensland or another state? Or if it was purchased online, was it purchased from within Australia online or from an overseas retailer? Mm-hmm. And people will volunteer that information to us.
Now, this may be a bit presumptuous, but we would be really interested in any data you can get from your schoolies testing, for example. Would that be obviously within the ethics of your test, your study? Would the committee be able to have access to that information?
I think so. I'd probably have to go through our funding body, through Queensland Health, because part of our contract is for Queensland Health to approve the release of the data. But I could definitely follow that up.
Great. Thank you very much. Any further questions?
Could I ask just a couple of follow-up questions? Sure. In relation to the work that you do testing drugs that have been used as substitutes for things that people have been prescribed as opposed to recreational drugs, what percentage of your work is the substitutes for prescription drugs?
I wouldn't be able to answer that off the top of my head.
Can you take that notice and come back to us?
I could. It's a small proportion compared to the other types of drugs, but it's definitely there.
And in relation to where people have purchased things off the internet, either through that channel or through the channel of recreational drugs, are there particular countries that people are purchasing things from that have popped up that you're seeing a lot of?
We don't ask specific countries. What we're interested in is it from overseas or within Australia? That's all we ask regarding that.
And final question is in relation to do you keep any data where people have come to be tested and they've handed in the drugs, or they've told you that they're not going to use them? Do you keep that data? And what can you tell us about that data? In what percentage of cases do people either hand over or tell you they're not going to use it?
So we are pretty consistent in those figures. So we're pretty consistently between 23 and 25% of people tell us that they'll use a lower dose after having a conversation with one of our staff. We also get, we did a report of our first 4 months of data, which got 23% using less drugs, and 16% of people either handed the drugs to us for disposal or would dispose of whatever they had left over at home. And those numbers are pretty consistent month by month.
Okay. Yeah. Good. No further questions? No. Thank you very much for your evidence today. If you've been asked to provide any additional information, please forward it to the Secretariat by no later than Tuesday the 12th of November 2024. Obviously, some of the stuff we've asked you will occur after that, but we'd still like it if you could. You'll be sent a transcript of your evidence, and we'll have an opportunity to request corrections to any transcription errors. And once again, thanks very much for coming today. It's been really interesting.
Thanks very much for having me.
I'd like to call the Brisbane North Primary Health Network to give evidence today. And I welcome you to give evidence. For the Hansard record, could you please state your name and the capacity in which you appear before the committee before giving evidence? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion.
Thanks very much. Thanks for having us. So I'm Libby Dunstan. I'm the CEO of Brisbane North PHN. And Caroline, do you want to introduce yourself?
I'm Caroline Radowski, the Executive Manager for Mental Health and Wellbeing at Brisbane North PHN.
So thank you very much. We welcome the opportunity to contribute to this hearing and particularly acknowledge the focus on AOD treatment and harm reduction. So Brisbane North PHN is, you're actually in the PHN boundary here. We cover just over 1 million people from the north of the Brisbane River up into Moreton Bay, a bit of Somerset. And we also provide some services on Norfolk Island. We've got a deep understanding and knowledge of our communities with a focus on delivering these services through commissioning, particularly to those most at need, and obviously work in partnership with our providers as well. So in relevance to this inquiry, what we're seeing at Brisbane North PHN are presentations to AOD services are increasing in complexity. Demand for services is high and continues to grow. We're seeing issues which we can talk more about in terms of fragmentation, in terms of stigma for people that experience AOD issues. We're seeing treatment delays. We're also seeing workforce challenges, and that's not just the size of the workforce, but also the skills and capabilities of the workforce. In our role as a commissioning organisation, we'll commission about $7 million of funding to 6 organisations in the North Brisbane and Moreton Bay region to provide AOD services and treatments. And many of these are providing those services to those at most risk in the community. And through these providers, we hear consistent messages about funding and challenges with funding in terms of being overstretched and under-resourced. Certainly, as I mentioned a minute ago, about the workforce and about how these providers recruit, retain and have the skills in terms of being able to deliver the services that they require, and challenges in meeting high demand. So our services, as an example, have about a 3-month wait to get into them as well. From a contracting perspective, the funding flows to us from the Department of Health and Aged Care, and so we see uncertainty in funding outlooks, certainly problems with lack of appropriate indexation, and this is putting further strain on our AOD providers as well. We've seen a notable shift in AOD client complexity, compounded by co-occurring diagnoses, things like depression, anxiety, borderline personality disorders, schizophrenia. And so AOD treatment has become increasingly challenging for the providers that we commission. And in fact, about 70 to 80% of clients in our region have co-occurring mental health and AOD presentations. We hear that stigma continues to be a significant issue for people receiving appropriate and equitable quality care. So people being reported as being turned away from health professionals and also refusing service. We've done some research in collaboration with CUNADA, the peak in Queensland, which shows that primary care practitioners consider they have limited knowledge and or confidence to deliver basic alcohol and other drug assessments and brief interventions. And this, coupled with fragmentation of referral pathways and high demand, also increases the reluctance of primary care providers to explore AOD issues. It's just simply how do we support people when we actually identify them in primary care? So despite the National Drug Strategy being in place, what we're seeing on the ground is a lack of funding to support the critical pillar of treatment and harm reduction in our community, despite this growing demand. And the cost of living pressures are obviously exacerbating that as well. So just finally, I think some of the things that we'd like to see is flexibility to fund, proven evidence-based, place-based solutions that respond to the needs in our community. We can talk a little bit more about the regional planning process that the PHN undertakes with our local hospital and health service, which really gives us a roadmap about service needs and gaps and guides our commissioning decisions. But we really need to make sure that we build a strong focus on building a highly skilled AOD workforce. And we'd also advocate for extending and providing more certainty around contract timeframes with adequate levels of funding so that we can actually address the significant demand in our community for AOD treatment and harm reduction programs. So I might leave it there, and we're happy to take any questions on what we've had to say.
Good.
Yes, I wanted to ask you a little bit about to what extent you compare what other primary health networks are doing, and whether your $7 million for the 6 projects is in line with what other PHNs are doing?
So that I wouldn't be able to answer specific in terms of amounts of funding that other primary health networks are funding in terms of AOD services. What we do have in Queensland, amongst the Queensland PHNs, is an AOD network where our commissioning staff come together to understand what each other are doing and sort of compare notes and make sure that, we're learning from each other as well. And each PHN...
How many PHNs does that involve?
So that's 7 in Queensland.
And it's 7 out of how many PHNs
There's
are in Queensland?
There's 31 PHNs nationally.
And would the other PHNs not engage in the commissioning of alcohol? I'm trying to get a sense of, and I understand you're an expert in what's happening in Brisbane North, but I wanted to understand how what you're doing is replicable in other places as well.
Yeah, so all 31 PHNs nationally would have an AOD schedule as part of their core funding arrangements with the Department of Health and Aged Care, and within that there would be particular requirements to commission particular services. Some of that is in a mainstream context. Some of it certainly is focused on delivery through community-controlled health services in the First Nations space. So each PHN does undertake commissioning activity in AOD, but what they commission and how they do it probably differs depending on local context.
And how do you make the decision about how much of your budget to allocate to AOD, and how do you make the decision as to how many services? What are the criteria you're putting forward to?
So in terms of how much funding goes to AOD specifically, that's probably predetermined for us by the funding agreement that is delivered to us from the Department of Health and Aged Care. So there is an allocated pool of funding for AOD. And then within that, we make decisions about who and how we commission. As I sort of said in my opening statement, it's not enough to meet the demand. So then you have to make decisions about where you'll get the best bang for buck in terms of, and I guess the lens we would probably use is who are most vulnerable or perhaps have the least access to services, and how do we plug those sorts of gaps as well.
And do you get that from a sense of the GP data that's sent to you, or
we do that through
centrally collected data? How do you?
So we do that, and look, most of the commissioning decisions around the AOD services that we did, we undertook that process some years ago. So we've been working with similar providers for a period of time. So we do that in a range of ways, and I guess each PHN undertakes a health needs assessment, and we certainly have a focus in our health needs assessment around the impact and the prevalence of AOD issues in the Brisbane North region, but also the mental health AOD and suicide prevention regional plan, which is a requirement of us to undertake, also kind of maps out, I guess, priority areas of action for us in the AOD space, and we do that in partnership and in collaboration with providers and community, so that when we're making commissioning decisions, it's not only based on the data, but it's based on what community and providers are telling us the needs actually are.
Can you very briefly tell us what the 6 programs are and the groups they target?
I can, just bear with me. Yep, got them here. So we our commissioning is we fund Brisbane Youth Service, so they focus on young people aged 12 to 25. We fund the Institute for Urban Indigenous Health, so they obviously provide treatment services focused on First Nations people. We fund Lives Lived Well for treatment services for 18 plus. We fund QAIAS, and I have got their acronym if you need me to spell that out, but I'll just have to go back. But their treatment services, again, predominantly for First Nations people. We fund QNADA, and they support workforce development in the AOD sector. And we fund QUIN for treatment services for above 18 plus. So they're a bit of a niche provider as well. So that's briefly.
You mentioned the increased complexities. Is that because there's increased complexities in the crossover between mental health and AOD, or are you referring to other complexities there? that you're seeing?
Yeah. So it is mainly to do with the complexities related to mental health and the co-occurring conditions. So most people that access an AOD service, so I'd say 71% to 81% of the people that are accessing one of these services do have a co-occurring complex mental health condition. Yeah.
So if you were to make a recommendation from this committee to the Minister for Health about the way in which we should better fund or better provide something for you to deliver at the PHN Level 3 commissioning services to incorporate this complexity, what would that recommendation look like?
So that's a good question. We would like definitely some more flexibility in terms of the funding, so we can deliver more place-based models and also outreach models. We'd also like to have a model where we can have a more dual diagnosis focus and also funding on the early intervention end, so a more holistic approach.
Can you explain how the present model is making it difficult for you to do the dual diagnosis?
Yeah. So the segregation of the funding, essentially. So if you enter a mental health service and you come, I guess, with a substance use disorder as well, often what happens is that you'll be segregated back to the AOD sector, and then you'll be asked to essentially work with your substance problem and then come back to the mental health service. So straight away you're fragmented in that way. And then what often then happens is that the practitioners on the AOD side don't have the mental health practitioners, and it's very difficult to treat somebody separately with those two areas. You need to treat them, I guess, holistically as a person.
So the issue is not just a regulatory one in that it's not just that we're saying, well, here's the bucket for mental health and here's the bucket for AOD. It's also a personnel issue too, because you don't have the people that can look at both issues in terms of the medical.
Yeah, there's a huge gap actually of people being trained as dual diagnosis practitioners. So often you're trained in a stream of psychology, it may be, and then you need to do further qualifications to work with substance use disorders.
And that's a good segue to my final couple of questions. Is that what you mean by the workforce challenges? It's finding, so you're looking for medical practitioners, not allied health people, not nurse practitioners, medical practitioners who are engaged in being able to diagnose and treat both AOD and mental health.
It's a variety. So from the general practice lens, we can't even get general practitioners doing opioid substitution programs at a basic level. So there's a huge shortage. We can train them, but then does that equate to them seeing clients is something. We have a retiring workforce on that end as well. So we're having a lot of people that aren't being supported once that general practitioner retires. There's a huge demand for addiction medicine specialists, but there isn't a lot of people trained in that direction. And then in the allied health perspective, the psychologists, they're very limited in this sector, and that will work in this area. And also, if they do, then they need to receive further training. And the remuneration is, again, another factor that plays into that, because the funding doesn't keep up with the indexation on the SHADS awards. So when you're looking at what staff you're recruiting into these areas, you're not really getting people with the high-level qualifications, because they're trying to use as much workforce and as much diversity in that workforce to meet the need that is out there.
If I can just add one point to that, I think that's kind of also that point around contract lengths as well. So, I think that the challenge that we have in this sector is not certainty in funding in terms of, 3 to 5 year timeframes. So when you're trying to recruit and retain appropriately skilled staff, short contract lengths are also playing a part in providers not being able to retain and also appropriately upskill their workforce.
Thanks, that's very helpful.
Thanks, Michelle.
There's definitely some alignment between what you're saying and what some of the stakeholders have said with respect to, for example, the duration of funding. A lot of people have said to us, stakeholders, the people who provision the services, have described the fact that they would like 5-year block funding. And you're essentially saying the same thing. And by the time they skill up their staff, they've contracted them out, they then lose them. And it's just a huge loss of corporate memory from the sector. So is there a mechanism right now for these PHNs, all of you, all 31 of you, to feed back to the department? Like, what is your feedback mechanism? What does that look like?
So, I mean, obviously we have a direct communication line to the department, and we raise these challenges with the department constantly.
Who do you, is it with the secretary or is it with someone lower than that?
It's usually not as high as the secretary, although, I mean, we at times have raised it at that sort of level. So we would usually raise it at an assistant secretary, first assistant secretary level. Because I guess what kind of happens from our perspective is, say, funding ceases on the 30th of June, we would be having those conversations now, because you actually, you know, if you think about people's livelihoods, what the extension of funding usually occurs in a budget process. The budget occurs in May. And so, you know, if I'm paying a mortgage and I don't have certainty, I'm going to go to usually a state health, run facility.
Is there no mechanism for you to speak directly, all 31 of you, to the health minister?
So we do speak to the health minister on a variety of issues. Generally speaking, contract. We have raised this issue with the health minister.
Is it a kind of a ad hoc kind of thing with the minister, or do you have a designated forum like a conference or something where you sit down and it's ad hoc? Okay, so one mechanism might be to just create a much more direct line of communication with the minister on a regular basis. Would that be useful?
Look, I think so. Provided then that the department is then able to action, I guess, funding decisions quicker than what's happening at the moment. So, whereby, really for providers, people need at least 6 months' notice. Otherwise, they can't plan.
Could you also just describe for us what a typical commissioning process looks like?
Yep. So, I mean, I guess each PHN, and including ours, has a defined commissioning cycle or a commissioning framework, and there's essentially 4 elements of that. So, the first is, the needs assessment cycle, or part of the cycle, where you're actually understanding what particular needs are. And once you've identified those needs, you move into co-design, and that's where you are working with providers and community to think, well, this is what the need is. How would we design services to meet that need in accordance with, local sort of community requirements? And then we would move into a procurement phase where we would procure, usually through an open tender, but sometimes through other mechanisms, an appropriate provider. And then there's, I guess, a monitoring and evaluation phase. So is that provider, delivering in accordance with what was expected? What challenges are they coming up with? How do we work together to overcome those challenges? And it's kind of then a cyclical sort of approach in that regard.
So one of the issues we've been hearing is that AOD problems in patients are chronic. They're chronic, going for years, sometimes a lifetime. And this kind of short bursts of funding, it's not working for the providers, it's not working for the patients. Yeah. And then we're losing workforce as well. So why have we not why have we not fixed this at the Canberra level? I mean, it's not like patients with alcoholism, for example, are going to be fixed in a very short period of time. It might take many, many years, maybe decades. So why do we persist with a model that's clearly not designed for chronic disease?
Yeah, so I think, PHNs in particular are funded under grant opportunity guidelines. So we're grant funded. That is the mechanism that government uses to pass funds through the department, through a PHN.
Could we not create a tranche of grant funding that is enduring? For well-established, well-functioning providers who know what they're doing, and we allow them, give them certainty, and we allow them to expand.
Yeah, we would absolutely welcome that. I mean, we absolutely understand the need for, this is public funding, so we absolutely understand the need for transparency and accountability, but I guess we would welcome more certainty and, in this particular issue, more appropriate levels of funding to match the actual demand that we're seeing in the community as well.
So just to round it off, you would welcome a model whereby you were given a tranche of funding for your well-established, well-functioning services, right, that you've known for a long time, that know what they're doing, and then perhaps another tranche of funding which would be designed specifically for new services or that would need to be provisioned.
To meet emerging needs or to progress particular innovations, to support training and capacity development. But yes, and I think the key to that is moving away from 1 to 2 year funding cycles and to more longer term funding cycles to allow not only the PHN but providers to actually plan and
I'm so
deliver.
surprised this has not been dealt with. I'm actually amazed this has not been dealt with. The other thing is you mentioned that GPs have, you're one of many people who have said this, limited knowledge and confidence and are reluctant to engage, and I completely understand that. You also had a survey. Do you think we could have a copy of some of those results?
Yes, so can provide that, after today is just a summary of that. So we commissioned QNADA to undertake some research in this area, and we're happy to share those findings.
That would be great, along with some quantitative data would be
And I think, in terms of, what we're hearing is that there are not a large number of, as Caroline was saying, a large number of GPs with specialist interest in AOD. And so even though as a PHN we're looking to provide training and upskilling, we certainly hear, that stigma and stereotyping are an issue, the complexity of those presentations. So even as a GP, when you have someone present with a substance disorder issue, it's about how to navigate what is a very fragmented system with long waiting times, and also just low remuneration. So there aren't a lot of MBS items that really incentivise the GP to work with that complexity.
There is on the issue of training up and skilling up a workforce, GPs included, as well as we were talking earlier about a peer workforce, and really bringing the sector together, because the workforce is absolutely everything to this. What kind of models have you looked at? Are you familiar with the Project Echo model?
Yes.
You are?
Yes.
Great. Okay.
Yep.
This is the hub and spoke. I have no idea why we have not scaled this up in Australia in community care. It's just a no-brainer in terms of at least having a model which can evaluate outcomes as well as connect a community of practitioners together. And would you be keen on seeing some funding towards enabling PHNs to perhaps coordinate something like that?
So I think that would be most welcomed in terms of, using, that sort of a mechanism, but also other mechanisms whereby, there's evidence-based training to support uptake, as I was saying, of even brief interventions in the primary healthcare sort of setting. So yes, we would welcome some targeted funding in that.
One of the challenges I found is that guidelines are fantastic. It's great to have guidelines, but no one reads them.
No.
Right? Busy practitioners do not read guidelines. They have no time for it. So, but they do partake, particularly GPs, in CPD, and something like a Project Echo model could actually incorporate CPD plus connect GPs with the experts, whether they be peer clinicians or health worker, other health types of health workers or specialists, and and then you see uplift throughout the workforce.
Yes, and I think that, complemented. So in PHNs, we also use something called health pathways, which is really about it is about that evidence-based practice, but also those referral pathways. So when you do have someone that presents in primary care, there's a pathway for the GP to understand where they might be able to get support for those that they can't manage in general practice alone.
And you provide that, do you?
Yes.
Okay, that's great. Thank you very much.
Thank you.
I just wanted to talk to you a little bit more about the GP workforce. How many GPs in the Brisbane North PHN?
So we have around about 340 practices and just over 1,000 GPs.
And how do you interact with them?
Through a variety of mechanisms. So I guess, everything, you kind of have a blanket approach in terms of, standard sort of communication and alerts and things that go directly to the GPs. We also have, I guess, a practice support team, so we have staff who actually work with those practices and the GPs on particular quality improvement and practice support sort of issues. And then we have sort of targeted training and sort of support programs that GPs, if they're interested in that sort of area, can participate in as well.
And do you know how many are interested in the AOD space and whether they are doing any training or?
We don't have that statistic on hand. We can ask QNADA to probably
we can check if we can provide some. I mean, we have undertaken some training recently, and we can give a bit of a sense of uptake. But my anecdotal feedback would be it's not. We're not. The door's not being beaten down in terms of uptake of sort of the training. I think general practice is a really busy space. And so I think, you're really trying to identify those practitioners that might have a particular interest in developing their skills further.
Well, we have heard it's a struggle to get the medical workforce engaged for a variety of reasons. Do you provide any other supports for the general practice community? Like, do you provide any agency to help referrals? Because obviously if you're in a busy GP practice and someone comes in with a drug and alcohol problem, waiting 3 months not going to be effective. Do you provide any supports for the GPs in that space?
I mean, it is a challenge, I think, in that regard. So I think we've talked a little bit about health pathways, which not only documents the sort of the evidence, but the referral pathways that are available in the Brisbane North region, notwithstanding, as we've discussed, that some of those have significant wait times. I think we've started with the commissioning of flexible funds that we have looked at things like social prescribing and complex care coordinators based in general practice. So we've got a pilot in the Caboolture region called the Care Collective. Now, it's not specific for AOD, but it is actually about noting that GPs, their business model is fee for service. When you have someone with increased complexity, fee for service doesn't really work well. So what we have been funding those practices with, a certain cohort of high complexity patients is a complex care coordinator to help with help with the care planning and connection with services. And in what we've been able to demonstrate with that sort of a model is that we can reduce presentations back to hospital by about, I think it's 75%. So we know those sorts of models
you have
work.
Data about that we could have access to?
Yeah, we can share that data as well. So, but I think it's kind of blending that fee for service model with, I guess, some particular roles embedded in the general practice to support patients that require a bit more complex care coordination and linked to services. Yeah, and it's block funded. That's right.
And the other thing is, which was very interesting for us, we visited the Princess Alexandra Hospital. Is that in your PH?
No, it's the other side of the river.
Oh, okay, right. Do you have any interaction with that unit?
No, not overly. That would be more linked to Brisbane South PHN. So, but we do work very closely with Metro North Health. So on our side, that's the Royal Brisbane, Prince Charles, Redcliffe and Caboolture hospitals.
Okay, okay,
Yeah.
Good. How do you think we could make the system better in AOD management?
That's fine. So I think we've talked a lot on the primary care end. Some of the solutions are actually in the early intervention space, because often what we're seeing in the presentations is that it's the social determinants around those people that is leading them into substance use. We've got many people that will engage with substances and it's not problematic, right? And then there's a small percentage where it does become problematic, and it's the other pieces around their life that is going wrong. That's why I was talking about that dual diagnosis and intersectionality. So there's definitely a piece, I think, in the early intervention space that we could really support. The flexible models of funding. So again, we've been talking a lot about treatment and a lot about accessing treatment, and there is absolutely a piece for that, but we need to start getting around, some healthy community type broader prevention strategies around the community, and how do we build resilience in the community, and ideas around that. So that would go a long way. The other piece to it would be is funding, I guess, that matches even the SHADS awards increases, the indexation to retain the workforce. As Libby mentioned, funding that is long term, because when you work with people in this space, they're not going to come out of a service in 2 to 3 months. It's going to take a long engagement, and there's a lot of stuff for them to work through in each of these services, so longer funding envelopes. And one of the models that some of these services offer, which works really well, is the wraparound service delivery piece. So often when we come with when somebody presents, we can fund the AOD treatment arm, but if we can't fund the other pieces that's linked to that, yeah, absolutely. Absolutely. So you're not working with someone holistically in that space.
And probably the only thing I would add to that is that, there is a national drug strategy.
Yes.
And in terms of what that, I guess, governance looks like at a national level. So, how do we know that, that we're delivering against the intents of those strategies? What are the challenges that the sector is facing?
We don't know what's working and what's not.
Yeah. I mean, I think, that a much more sort of formalised governance arrangement that involves, not only PHNs, but, the sector itself, but also people with a lived and living experience of AOD issues really would provide important advice to government, not only about where that strategy is at, but where we need to go, and having a really clear roadmap. I think the strategy runs out in 2026. So it's actually not that far away to be thinking about where do we need to go in the future. And so I think government has a really critical role in identifying and setting the priorities to address this particular issue.
Yeah, well, I mean, it's not all about me, but I think in particular we've got to bring the community with us, and I don't think we have done that. I don't think the community understands what harm reduction means. I don't think the community understands what the dangers of alcohol are, really.
No. We've had a strong kind of focus on, I guess, not on the harm reduction, but on the sort of supply and criminalisation and those sorts of activities. But we need to be also, I guess, helping the community to understand the sort of harm reduction treatment and the early intervention work, and that's often not funded as well comparatively to the policing and that sort of side of things as well.
Good. All right. Well, thank you very much. Yeah, of course.
I've written down that you quoted a statistic that 71 to 81% of people presenting had a co-condition. Is that your own statistical, and can you share that with the committee? Because I think those sort of figures are really powerful to be able to explain why particular recommendations are necessary. So if you wouldn't mind providing those to the committee, that would be great. The biggest thing that we've heard over the last 3 days is stigma, and the stigma is causing issues with workforce. It's causing issues with people who have addiction or are setting themselves up to addiction for admitting it or getting treatment or whatever the case may be. As a PHN, have you considered or has anybody come to you with some sort of funding request to deal with that stigma, or do you think that that sits sort of in the broader government remit of campaigns explaining what's going on, awful things on bottles of wine that nobody ever reads? I just wondered whether you'd considered that as a PHN.
It's not something that, look, as we've talked about, we're certainly seeing that as a significant issue. And, I think that's not just the people that we're commissioning services through, but, we would have those conversations so that, with the peak body, so that being in Queensland being CUNADA. And I think that because it's a shared problem, I don't know that there's any one thing that any of us could do, but I think if we're thinking about our regional sort of planning process in Brisbane North, which is a collective of our stakeholders, then it's really about what do we need to do collectively to address stigma and ensure that people are not delaying access to treatment, that they feel that they can talk to their primary care provider about their drug and alcohol issues, and we're seeing, anecdotally hearing that that's problematic. But it's not something that the PHN specifically, I think, has owned, but it's certainly something that we talk about with our providers as a particular issue that is problematic in our region.
Okay, thank you. Thanks, Chair.
Mr. Lisa.
I just wanted to ask a supplementary question. You represent mainly the CBD is a large part of your area, isn't it?
Yes.
We hear a lot about the social determinants here, and I don't doubt that they're real and that they focus particularly on people of low socioeconomic background or people that have other issues in their life, abuse and the like. I wanted to ask you, given the population you represent, to what extent should we be paying any attention or be thinking about people who work here in the CBD who are from high socioeconomic backgrounds, who are significant drug users? What what should we be thinking about that cohort of people in the context of recommendations that we would make in the inquiry, and to what extent do they come across your bailiwick? I think about bankers, lawyers, all the people that we're quite unsympathetic to in many respects, perhaps using cocaine or MDMA or other party drugs. To what extent should they be considered, and what are the things that we need to think about in dealing with that population?
Not even always illicit drugs. I guess it's also thinking about over-the-counter medications or things that perhaps aren't being used in accordance with how they should be used. And I'll let Caroline answer that, but just noting that, so, with our 1 million people, yes, we've got that inner city region, but then we have quite significant outer metropolitan sort of regions. So it's
I don't doubt that, but no one talks about this group, and
No.
I want to ask you, given that they're in your bailiwick.
I mean, there's certainly a group of people in the inner city that do have that substance use disorders as well. I guess the main thing coming from a more affluent background is the problem of stigma and accessing treatment, and how discreet that can be, and access being timely and available after hours is generally what we hear from that group of people.
What about a prevention message for that group too? I mean, I suspect the prevention messages don't work in that group for whatever reason.
Yeah, that was talking more around that holistic approach when I was talking about the early intervention. How do you manage stress? How do you manage family dynamics? Those sorts of early intervention strategies before they start the substance use, and where can they access support, I guess, before they get there? Because often what we'll find is that it's substituting for something else that's happening in their lives, and how do they cope with the various pressures, particularly in that group of people. I guess my experience has been delivering AOD services in inner city Melbourne prior to this role, and I had tried some of those strategies, and it was really about the PHN delivered after-hours services that people would access, that they were available in a discrete place as well, harm reduction framework, and also trying to meet them, I guess, at their point of readiness, and connecting them with general practitioners that were able to see them, I guess, and not I guess reject them for an appointment, that sort of thing. What we often found with city workers, and that's not different to Brisbane when you talk to these our providers here, is that they might live further out, but they'll access their treatments in, so they sort of keep their services separate as well. Yeah.
Thank you.
Good. Thank you very much. We've run out of time. Thank you for your evidence today. If you've been asked to provide any additional information, please forward it to the Secretariat by no later than Tuesday the 12th of November 2024. You'll be sent a transcript of your evidence and will have an opportunity to request any corrections to transcription errors. And thanks once again for coming today.
Thanks for having us.
Now call the Alcohol and Drug Information Service to give evidence today. I'm glad you're worried. I welcome the Alcohol and Drug Information Service speakers today to give evidence. For the Hansard record, before giving evidence, could you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. That giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion, and thank you for coming.
Good afternoon. I'm Kira Palmer. I'm the Acting Director of ADIS 24/7 Alcohol and Drug Support, formerly known as the Alcohol and Drug Information Service.
I'm Dr. Jeremy Haylar, the Clinical Director of the Alcohol and Drug Service, which is part of Metro North Mental Health.
ADIS 24/7 Alcohol and Drug Support. is a 24-hour telephone and online service supporting Queenslanders with alcohol and other drug concerns, their loved ones and health professionals. Our team of counsellors work across a 24-hour roster to provide accessible, time-limited support, counselling and referral. ADIS can reach people via telephone and online chat on our website. We offer an automated SMS support program and are working on new online offerings to enhance accessibility. ADIS provides a direct referral pathway to clients who are seeking treatment in over 100 sites across Queensland, across a spectrum of treatment types. The Alcohol and Drug Clinical Advisory Service, also run by ADIS, links health professionals with a medical addiction specialist for advice on patient care for alcohol and other drug concerns. ADIS can offer time-limited multi-session support for clients and has a suite of health information and promotion materials. ADIS is often the first point of contact for people seeking support for alcohol and drug concerns, and we know that it can take years for people to take this first step. ADIS, much like other alcohol and drug services, aims to provide evidence-based treatment to provide positive outcomes for our clients. Enhanced funding in recent years has increased the provision of alcohol and drug treatment in Queensland. However, we're aware that there are still major service gaps that our clients experience. Waitlists for treatment are long, especially for longer-term residential rehabilitation services in the non-government sector and government and non-government organisation counselling services. The single centralised inpatient public withdrawal service, the Hospital Alcohol and Drug Service at the Royal Brisbane Hospital, usually takes 3 to 4 weeks for a person to get in. Therefore, inpatient withdrawal management, or detox, is not available for free in much of the state, and individuals are required to travel away from their support systems to seek help. Connections between and within government and NGO-based services are not necessarily always streamlined, making this a difficult system for our clients to navigate. ADIS clients who use opioids often report frustration at the needs not being met due to the lack of capacity within both public clinics and private prescribers for the Queensland Opioid Treatment Program. There's a lack of information in the community and about the few private prescribers, and clients cannot access details for specialists to seek referral. These clients are often at risk of overdose and lapse, and the lack of information sharing can be a barrier for them accessing treatment. For no other medical condition could you not get a specialist referral from a GP at a high-risk time. People with alcohol and other drug concerns still experience stigma, not just from the general public, but also people are reporting stigma within the healthcare system, especially in cases where frequent ED presentations for substance use or mental health concerns are occurring. We've heard reports of clients accessing harm reduction services such as the needle and syringe programs within hospitals and experiencing stigma regardless of the safety that these services try to create from the other parts of the hospital, more likely. Moreover, clients call frustrated that vending machines that are put in place to support them when the needle and syringe programs are closed are sometimes broken or vandalised, thus impacting on the effectiveness of our harm reduction services. Clients experiencing stigma and negative healthcare experiences can further isolate them, increasing their health concerns and reducing their likelihood of seeking help. Larger campaigns tend to focus on the harms of alcohol and drug use to individuals and communities, potentially further isolating people who use substances. And this often misses the opportunity for a message of support being available. For example, alcohol, much like tobacco, a legal drug causing health and psychosocial harms. However, the only warning label on the bottle of alcohol is for risk during pregnancy, whereas the quitline number appears on cigarette packages. Where substance dependence is depicted in the media, Lifeline appears as a service of support quite often, with people often being redirected to the national AOD hotline. We see the opportunities for promotion of these services and to send a message of support to clients. The majority of services that are funded are tertiary, and therefore there is often a gap in prevention and promotion. Some programs deny that substance use is a concern. For example, there's sometimes limited support in schools to address the rising use of substances in school-aged children, missed opportunities for harm reduction services in the community and within vulnerable communities such as the prison population. We know that a large portion of individuals seeking support for substance dependence have a history of complex trauma, and therefore there is a need for broader societal interventions and support for parents, children and young people. Alcohol and drug use has to be seen in a wider context. ADIS counsellors respond to clients experiencing domestic violence, child safety concerns, homelessness, relationship difficulties, comorbid health and mental health issues, risky behaviour and overdose, to name a few. ADIS clients report a lack of housing and financial support, complex mental health concerns and isolation, leading to exacerbating their substance use and then in turn creating more consequences for them and their loved ones. When there are waitlists for government-funded counselling services, the alternatives such as accessing a GP and a psychologist through a mental health care plan can be costly and lead to further financial stress. Treating the underlying cause of alcohol and drug concerns can be difficult when there are gaps in other systems for support. IDIS is also a provider of the Police and Court Drug Diversion Program, and a recent expansion of the Police Drug Diversion Program appears to have initially reduced the demand on courts for substance use concerns, thus also reducing the impact on individuals. We feel that further opportunities remain to provide a health response for these concerns and reduce the impacts of fine orders and prison for people suffering with alcohol and drug concerns. Changes in policy could also further reduce the stigma experienced by this vulnerable population, viewing and managing people with a substance use disorder through a health lens rather than a law and order lens. Thank you.
Good. Well, I might just start with a couple of questions. I'm assuming that you are the first line for most inquiries in Queensland. Can you give us an idea of the number of people that are contacting your service?
Yeah, so we receive about 3,000 phone calls a month from people in different parts of Queensland. We tend to have a smaller number of those contacting also via web chat. So we opened web chat in 2021, and we get about 300 contacts on web chat. And yeah, I guess we're seeing a lot more, and I guess this is a population thing as well. We do see a lot more people from more of those metro areas calling through, but we're trying to get into
data on that, like age, sex, more comorbidities. Can you give us?
Sure, off the top of my head. So
you can take it on notice if you like, but it'd just be And what percentage are alcohol? And what percentage are other drugs? That would be interesting for us.
I can provide the specific numbers later. Our primary drug of concern that is reported through our 1-800 number is alcohol, followed by cannabis and methamphetamine.
What sort of proportions?
Probably about 40% alcohol. We also have 30% of our callers are significant other or family members as well. So it's not always the person with the drug and alcohol concern that's calling us. And yeah, a lot of our primary drug of concern data aligns with, I guess, what we're seeing across the National Drug Household Surveys, things as well. But I'll have to provide the actual numbers to you later.
If you could take that on notice, that would be great.
Yeah.
Yep. Good. And do you have specifically trained counsellors, much like the sort of Lifeline programs we have in Sydney?
Yeah, so we provide a 4-week onboarding training to our counsellors. A lot of our counsellors come to us with undergraduate degrees in either psychology or social work or something in the human services space. However, we do also provide onboarding training for them to be professional counsellors, as well as onboarding
and they all
CPD.
paid? There's no volunteers?
They're all paid, and they're all paid for their training. It's not a program that you can opt into and volunteer. It's being successful in a recruitment process to obtain employment and then being employed by our service.
Good. And what are the frustrations that the counsellors are reporting?
I think one of the biggest ones at the moment is managing expectations of community, people accessing help, especially with some of those things I've mentioned in terms of when somebody is seeking support for their substance use concerns, it's often I need it now sort of expectation. And when there's wait lists for other services, we refer into a large amount of sites across Queensland and different treatment types to be able to do that referral at the time and collect that information from them, but then provide that information that maybe there's a 3 or 4 week wait list to get into somewhere is a really big frustration for staff, because we also want to be helping people to get the support that they need when they need it as well. So I think that's probably one of the pressure points. I mentioned Queensland Opiate Treatment Program. ADIS used to hold a list of private prescribers, which we no longer have access to that information. So we don't actually have the information readily available to clients as to who they can contact in the community.
So if someone brings up with concerns about an opiate addiction, you used to be able to refer to certain...
We used to be able to give them the contact details and information about a prescriber in their area, and we don't have that information anymore. So it's often now just relying on public clinics.
Why is that?
there's been an introduction of a system called QScript for monitoring the medications, and doctors haven't consented to provide their details publicly through that system. So there's a big information gap around. Yeah, we get people contacting a lot, and we just have to kind of give them what we have, but we don't always have accurate information as to who's available.
So,
and where
so
they
why don't doctors want to make that?
I don't think the system allows for it. I think there's bigger system issues with this.
I think it's fair to say they've probably got enough to do already, so taking on this extra cohort of patients is not necessarily very attractive. People don't always show up for their appointments, so you're running a small business. If you have no shows, then that impacts on your bottom line. So there are competing demands for GPs. They've got more than enough to do already. I think that's really the core of it.
Right, okay.
And I guess just not having the ability to give access to treatment to everyone within a public setting means that, you know, we do have a reliance on our GPs that quite often don't have the capacity to see many people under the program.
And sorry to be too granular, but what happens if a relative rings up? How do you, and say I've got a son with an alcohol problem or other drug problem, how do you manage that? Because obviously there are privacy concerns.
Yeah, of course. I mean, we treat the client as the person who is calling us. So the client on the other end of the phone is the family member. We provide support and information for them at the time as to, you know, maybe some of the parameters around what's available in terms of treatment. So, for example, there isn't mandatory drug and alcohol treatment within Queensland. So there isn't an parents might have an expectation that they can get their children into care, and that's not the case. So setting some of that scope around what we can provide, but also, I guess, providing opportunities to engage that family member. What's the biggest issue that's going on within their family? Is it communication? Is it talking with your loved one? How might you communicate with them better? Are you looking after yourself? Because often they're calling us when they're at the end of their tether. They're feeling quite burnt out by what's going on within their family. So, just really focusing that call on, we can give you what information you need and we can answer your questions, but, are there particular things you could be doing to support your loved one as well as yourself in that moment? We would encourage, if their loved one was ready to seek treatment, that they would give us a call to discuss options in the future.
And do you do follow-up of the clients who ring? Do you?
We ask for, if we provide a referral, we get the feedback from the service to find out whether or not they have been accepted and engaged in treatment. We do have a feedback loop, so we do send out a survey to get follow-up from clients around the process and how they found it. We're the 1-800 line is a single session phone line, essentially. So a lot of the time it's providing the information or the intervention in that one phone call. They have the opportunity to call back at any time, and that's open to them 24 hours a day. But we don't have follow-up in that space. We do provide a 3-session program over the phone where we can speak to somebody for those 3 sessions, and it's somebody who's usually motivated and has a goal and wants that support kind of in that moment, where we can provide the same counsellor to them for 3 sessions over the phone. But essentially we've got counsellors who are on the line. We don't have sort of trained psychologists or social workers to do more of that tertiary end of ongoing treatment, but we provide more structured support.
And any trends that we should be aware of?
What are we seeing at the moment?
Well, the latest data from the National Drug Strategy Household Survey shows GHB use has dropped off slightly, vaping has dropped down slightly, methamphetamine continues to kind of battle with heroin as the drug of choice. I think the methamphetamine issue is kind of becoming more confined, so there are serious users who are continuing, whereas most of the population are aware of the potential harms, so it's becoming a kind of polarised situation where some continue using because they can't stop and others don't embark because they've seen the consequences.
Increases in abuse of cannabis? Or?
Well, the whole medicinal cannabis industry is causing great concern. There are doctors who are just on the phone prescribing to people they've never met
Yeah,
without
yeah.
a full history.
Sure, we're aware of that, but are you seeing more concerns from your...
Well, interestingly, it's colleagues in mental health who are seeing the issues, which is where patients who have mental health issues have accessed medicinal cannabis. Maybe they were using other sources for cannabis before. They think because it's prescribed, it's kind of legitimate, and they're presenting with psychotic illness and deterioration in their underlying mental health state. So that's a growing issue.
Sure, but you're not noticing any increased contacts?
I must confess I haven't seen a patient yet who wants to get off their medicinal cannabis and needs our help, which is interesting.
Yeah.
Although I do believe that has been a mention through HADS that sometimes there's been inquiries for detoxing from medicinal cannabis as well, and that's been the difficulty where the doctors who prescribe it don't actually do the withdrawal or support the withdrawal as well. So when someone actually wants to stop, it's not supported. We're seeing more in the space of our drug diversion clients who, I guess there's some legal implications still. So there's particular prescribed things you can do. You have to have it in the canister. You have to have, there's these rules around actually having the cannabis and also not being able to drive. So through that space, we are seeing people have different concerns from using the medicinal cannabis versus using cannabis in the conventional way.
Good, thank you. Julie.
The chair's asked most of the questions I was going to put to you, but no. It's great minds. I do want to ask you though about how you're funded and the length of your services. Purely state funded?
Yes, we're a government service.
And you've been how long have you been at this work?
How long of the service?
Yeah.
So I believe it was conceived when I was, which was 37 years ago.
More information than we
need.
And can I ask, are you purely an information service, or are you crisis, or how do you describe a particular role in that?
So I guess, and that's where the shift from Alcohol and Drug Information Service has come to. We now refer to the service as ADIS 24/7 Alcohol and Drug Support. We're primarily brief intervention counselling. So the client will call us in and receive a level of assessment, drug and alcohol assessment, brief intervention, and then we have referral pathways out to different services as well that we can directly refer into. So instead of that person calling us and telling us their story and then us giving them a number and then they have to take the next step to call the next service and then go through their assessment processes, we can securely share some information with them from the assessment that we have conducted in order to then get them into a service much quicker and provide that detail so they don't have to keep retelling their story.
My last question is to go back to this issue of the opioid prescribers and so on, just to understand that. Is that... It sounds like it's a state regulation that's preventing this happening. Is that right, or is it a federal regulation that's preventing allowing people to know who the opioid prescribers are?
I think the concern before Q-Script came along, we had a drugs dependence unit who would manage the opioid treatment program, and they became reticent about giving out doctors' details because there was such a demand which wasn't being met, that the doctors were being overwhelmed with requests. So I think it probably came from there that there was the view that we should just keep those contact details under wraps. And there's word of mouth, and people know various prescribers who will take on patients. And the public clinics have certainly improved their intake, so generally you can get onto treatment within a few days now. So several years ago it took several weeks. We've actually improved by getting more staff on board thanks to resourcing, and we're able to offer a more timely service.
Thank you very much.
Ms. Stanley.
Thank you for your evidence, though, but I don't need any questions.
Thank you. I really like your website, actually. It's really easy to navigate. While you've been chatting, I've done my alcohol quiz, and I am low risk. It was really quick and easy. So I just wanted to find out, do other states have a similar model? Do all of them have a similar model to this?
most states have an ADIS or equivalent service. So I believe it's Direct Line in Victoria, and they also cover Tasmania. We've got an ADIS down in South Australia, New South Wales, and WA.
Exactly the same.
We're not all the same model, but we do benchmark against each other, and we do have regular contact with the other services.
All are state funded?
That's my understanding. I can't speak for all of them, but.
So would the other states, for example, have this SMS support program, callbacks, online chat? Would they all provide that?
Not all of them. So we are the first ones to, it's my understanding, have the SMS support program. That was only launched in July this year. We know that Direct Line and WA, I believe, have the online chat. We copied them for that, and they'll probably copy us for some other stuff. I think most of the services we all have the 1-800 number, and we all respond to the national AOD hotline calls as well in our jurisdiction. And most of us are trying to, I guess, learn from each other and build our services up to offer support.
I mean, there's obviously an opportunity here for the Commonwealth to perhaps fund you all to a level where you're providing a very harmonised kind of service, right? When people are coming to you with urgency, as you mentioned earlier, and they're getting frustrated for waiting around for another appointment, what do you do in that period to support them? Or what can you do in that period to support them?
Yeah, and I guess so for some of them, if they are eligible for our 3-session program, we can offer support through that, so they can speak to a counsellor once a week on the phone. We'll obviously refer them back to whatever supports they have, if they do have supports in their community while they're in that wait time. Some of the services, I believe, might also have transition programs as well. So once you create the referral into the rehab, services like Lives of Well have counselling services as well. So they can receive that referral for one of their rehab services and potentially offer support or counselling there. We do have the ability to recommend within our referral if they do need some additional interim support as well. It's just we don't have control over what actually happens when the referral is received.
And is this, and when people go to an online search engine, does this come to the top of the search? Do you actually put resourcing behind the search to drive this to the very top?
We're working on that at the moment, actually. We're working on, because we're about to launch an online intervention program on our website where people can self-guide through some modules for information and advice. We are looking at what our website looks like in the future, and also noticed, we don't come to the top of the page when you search alcohol and drug, and we're really working on trying to promote that presence and make it really clear who we are.
Okay, I think it's fantastic, actually. I really like it. And you've got some great resourcing for clinicians that links to a whole website on up-to-date guidelines. I saw that. It's good. Thank you.
Thank you.
Just a couple more questions.
Yep.
What happens if someone rings up and they're in crisis?
We will manage that crisis. We're not essentially a crisis line. However, our counsellors are trained in suicide assessment and management, in child safety assessment. We're affiliated with under the Metro North Mental Health Service and Alcohol and Drug Service. So we have the ability to, I guess, use some of those resources in terms of our child protection liaison officers and people to seek guidance if there are particular concerns that we come across. We also have emergency services and MH call that we can refer into. We'll get people on the line. We can call an ambulance out to somebody. We can trace their call as well if we don't have their details to be able to find out where they might be. But yeah, we do respond to those crises. We don't promote ourselves as a crisis line, if that makes sense.
Yeah. And perhaps, Dr. Haley, you might be able to answer this. You're a clinician. In the alcohol space, we went to Princess Alexandra unit today, which was really interesting. Do you run a similar unit?
Not exactly the same, and it's not my direct responsibility, but the Royal Brisbane Women's Hospital, which is kind of the parallel to the PA hospital on the north side, they have the inpatient withdrawal unit called the HADS unit with 16 beds, and that kind of accepts referrals from all around the state for inpatient withdrawal, typically higher risk patients where ambulatory withdrawal done as an outpatient is less ideal. So they don't quite have the same unit as the PA has. It's really just the inpatient spell, and then patients are referred back to their original service.
And are there enough resources to manage the inpatient load?
Well, we heard earlier the wait time is 3 to 4 weeks.
Yeah.
And there's...
Which is actually not too bad when you consider some of the other places.
Well, I think we need to recognise the so-called teachable moment. So when someone reaches out and said, I've hit rock bottom, to use a cliche.
Sure.
To say, well, we'll help you out in
3 or 4 weeks, yeah,
is not really the response we would like to offer. Now, we can do something in the interim, and I think there's room to expand ambulatory withdrawal services. I think sometimes we're a bit cautious, some services more cautious than others. So we can offer, we have a 7-day service that's open every day of the year, in fact, and we accept mainly all comers unless they're very high risk. So that is an alternative, and we can respond much more quickly than 3 to 4 weeks. But for some patients, certainly the inpatient unit is ideal. Maybe they've had withdrawal seizures in the past, so withdrawing in the community is less appropriate. I think they could certainly do with a few more beds. 16 is perhaps not enough to serve the whole state. Now, I know there are initiatives to open up beds in other parts of the state, and that will maybe make a difference to the overall capacity.
Right. Now, at the end of this inquiry, we have to make some recommendations about federal policy. What would you like to see us do?
Well,
simple question.
I did bring a paper which I'd like to contribute to the committee about the return on investment, because after all, governments have to look after money, and if they can be persuaded that investing in a certain area will actually return dollars, not cost them more than they can expect to benefit, then that should create a very strong case for proceeding along those lines. I think one of the
if you could provide that to
happily,
the Secretariat, that would be great.
One of the areas I think that's seen some movement recently is the diversion issue. So instead of people found with substances on their person getting caught up in the criminal justice system, if we can use this health lens and move away from punishing people. It's said that about a quarter of those in Queensland jails are there for substance-related issues, and a very much higher proportion, half or more, have a history of injection drug use. So really that is capturing a group that would be much better managed with treatment rather than incarceration. So that really would be the strongest message I can offer today.
A decriminalisation message?
I went to Portugal in 2018 with the Mental Health Commissioner. Really interesting. They took a very bold step in 2001 to change the whole approach. They weren't trying to avoid the big criminals at the top who are doing all the dealing and supplying. It was mainly the street dealers that they no longer were going to be taken into custody and locked up and tried, etc. They had dissuasion commissions around the country where people would attend for a session, and that was it. And they might have a small fine. And the worry was that this would encourage people to use more substances. It hasn't done so at all. And compared with countries nearby, so Spain and other European countries, there's really been no significant increase in substances, whereas the rate of overdoses, which was the chief driver for this change, has dropped precipitously. So I think by most standards it's been very, very effective. Unfortunately, in recent years, resourcing has fallen off, and so they can't quite point to the same good results with rehabilitation, training people in furniture making, in other skills, which we went to visit one of their sites, and it was really inspiring that they were helping people to rebuild their lives, if you like.
Mm-hmm. And that, you're suggesting that doesn't happen in the criminal justice system?
I am suggesting it doesn't happen in the criminal justice. That's where you go to get hepatitis C. It's where you go to learn about drugs. It's where you acquire a drug habit. We think people locked in jail have no access to substances. This is rubbish. They've got as much access as anyone else. They just choose the ones that will help the time pass. So the depressants, like opioids, like benzodiazepines. Not many people use methamphetamine in jail because that just makes the time seem longer and longer.
Do you get calls from prison or not?
A little bit, yes.
So much.
So one of our services in Caboolture, they're near Woodford Jail, and there's almost a rotating door of prisoners or patients going round and round. So we do try to liaise with them to ensure a seamless service to continue their treatment and help keep them out of jail and out of trouble in the future.
Within the ADIS service, we do also receive phone calls from people who are seeking support for their loved ones when they're about to be released as well. And I guess that's one of the barriers that we see is the inability to refer somebody into a service without actually having contact with them. So quite often that is left to when they get out. Often parole hearings are held at 4 o'clock on a Friday afternoon, and it's not a lot of time to get someone into a service. So there is that gap when somebody does come out of prison, and now I guess we're seeing people who are prescribed opioids in prison, and we're trying to find creative ways within our services to keep them on the program when they come out as well.
We did hear this morning there was a lack of prescribers to be able to do that, so people are almost doomed to fail.
Yeah.
So in the prison system, people are actually injecting themselves with saliva and other foreign materials in order to get admission to the PA hospital, where they have a medium secure unit, in order to get commenced on opioid treatment there, so when they get back to jail, they can carry on. I mean, that is a desperate situation.
It's terrible.
It is.
Any further questions? No? We've heard a little bit about online services, and it sounds like you're looking to expand what you're offering. Is that going to require more funding?
No, we've already secured the funding through under Better Care Together to create that, and we've got a vendor that manages our website that will provide ongoing support for the program as
So
well.
it'll be ongoing funding.
But it's already been allocated.
Yeah.
Okay, good. Well, thank you very much. Thank you for your evidence today. If you've been asked to provide any additional information, please forward it to the Secretariat by no later than Tuesday the 12th of November 2024. You'll be sent a transcript of your evidence, and we'll have an opportunity to request corrections to any transcription errors. And once again, thank you very much for coming.
Thank you.
Thanks for the opportunity.
I'd like to thank also the committee members and witnesses for their time today, and I'd like to thank Hansard and the committee secretariat for all their hard work. It's been a very successful week, and thank you very much. And I'll suspend the meeting. Thank you.
Thank you, Chair.
Thanks.